A very good evening to all of you guys. This is Dr. Azam here, Faculty of Anatomy at Doc Tutorials, and a warm welcome to all of you guys. Let me just say this one here. A very warm welcome to all of you here. Yeah. Yes, guys, a warm welcome to all of you. I welcome all of you to the Doc Tutorials family here. We are actually conducting a quick revision program for all the 19 subjects for the students especially who are preparing for the INA SET exam. And as I said you, learning is always learning. So not only the students preparing for INA SET right now, even the students who are preparing for the other competitive exams like NEET PG and even FMG, yes, they can all attend this session over here, guys. So I think now it is perfectly fine. Everything is fine here. I request all the students who have joined me right now, just give me a thumbs up, guys, if you people are comfortable with my audio and video. Just give me a thumbs up if you people are comfortable with the audio and video here. Thank you, Bharat. A very good evening. Good evening, Shifana Abdin. Very good evening. Good evening, Ruhirai. A very good evening, Vikas. Thank you, Dr. Kadir. Okay, thank you. Yes. Now I got the confirmation from all of you guys. Now, my dear friends, without wasting any further time, let's get started right now. See, what is my main intention here in this session? What we are actually going to do? Normally, the students who are actually preparing for INA SET, they are at the peak of their preparation right now. Exam is very much nearby, and I think already you have prepared. Now, my intention here is, without wasting any further time, in like another couple of hours, I just want to revise all the very important concepts of anatomy which are required for INA SET, which has been like repeatedly tested in the last 2-3 years in the AIMS exam and JIPMER exam and all. So all those topics I have actually collected here, and we are going to discuss that, so that it will just give you an extra edge, extra confidence. Okay, these are the topics that is like must know. You have to know this topic before going to the exam, guys. Okay, so चलिए सर हम लोग start करते हैं without any further delay. Now, as we have informed all of you people, in this quick revision program we are going to discuss like 20 concepts in a couple of hours, in 2 hours. So welcome to the concept number 1. Now, yes, of course, Shubham Chaudhary, it is even important for the FMG. Why? Because concept will be actually concept here. Anatomy will be anatomy, and these are the important concepts. So at least learn the concept, it will be useful to you. So don't worry about the FMG also. Now, starting with the very first concept here, concept number 1. The concept number 1 I want all of you to study is muscles of hand, guys. Now, this concept, that is muscles of hand, is very much important for your INA SET exam. Muscles of hand, very much important for your INA SET exam here. The reason here, even in the INA SET exam which was conducted in 2020, there was a question regarding the attachment of muscles of the hand. Now, I'll tell you what exactly you have to learn here. See, we all know that there are totally 20 muscles of hand. We all know that there are totally like 20 muscles in the hand. There will be like 4 thenar, 4 hypothenar, 4 lumbricals, 4 palmar interosseous, 4 dorsal interosseous. We all know this very well. I am not going to teach you that again here. Nowadays, what they are asking in the exam is about the attachment of this muscle. So that is what we are trying to now update our knowledge. We are not going to study all the 20 muscles again, their names and all. We all know the names, everything. There will be 4 thenar, 4 hypothenar, 4 lumbricals, 4 palmar interosseous, and 4 dorsal interosseous. Now, out of all these 20 muscles, we are actually going to focus mainly on the attachments of those muscles right now. Okay, and I'll tell you exactly what was the question asked in the 2020 as well as even in 2019 also, based on the attachment. Fine. Now whatever diagram that you are able to see on the screen here, these are actually the lumbricals, guys. Whatever diagram that you are able to see on the screen, these are actually lumbricals here. Fine. Now these lumbricals, there are totally like 4 lumbricals here. Out of the 20 muscles of the hand, there will be like totally how many lumbricals, guys? There will be totally 4 lumbricals there. And this will be the lumbrical number 1 here, the lumbrical number 2 here, then the lumbrical number 3 here, and then there will be a lumbrical number 4. There will be totally 4 lumbricals there, guys. And the easy thing to understand here or identify the lumbricals, remember all these 4 lumbricals are going to actually originate from this tendon, and that tendon is flexor digitorum profundus tendon, FDP. That is your FDP tendon here, flexor digitorum profundus tendon. Okay. So FDP tendon, what will happen actually, flexor digitorum profundus, there will be like 4 tendons coming in the hand here, and from those 4 tendons what is going to happen, the muscle is going to originate, and that muscle will be your lumbricals. Now why is the name given as lumbrical? Lumbrical is actually worm like. You can clearly see in the diagram there, the muscle will originate from the tendon and then take a turn, and it is actually going towards the back, and it is going and getting merged or getting inserted along with the extensor hood here. Extensor hood here, there will be extensor digitorum muscle over there, the tendon there, and in that what is going to happen, it is going to insert. So it is going to actually go like a worm there and get inserted onto the extensor digitorum tendon there. Together like that is going to form an extensor hood. So first thing that you have to remember here, the origin of lumbricals will be from FDP, flexor digitorum profundus. Most of the students are writing there the volume is low. I hope the volume is comfortable there, guys. I'm even watching the video here. Hello. Just confirm me, like most of the students are writing there in the chat box that the volume is low there. I think the volume is comfortable here. Even like I am watching the same thing on my phone here. Fine. So that is about the lumbricals. Now out of all these 4 lumbricals, remember, we all know very well that the lumbrical number 1, that is your L1, and the lumbrical number 2, L1 and L2, these 2 lumbricals will be actually unipinnate. These 2 lumbricals, hello, yeah, the lumbrical number 1 and lumbrical number 2, these 2 will be unipinnate, whereas the lumbrical number 3 and lumbrical number 4, these 2 will be actually the bipinnate, and we can clearly appreciate that in the diagram also. So lumbrical number 1 and 2, these 2 will be unipinnate, and 3 and 4 will be actually the bipinnate ones, guys. And what about the nerve supply? The lumbrical number 1 and 2, these 2 will be actually supplied by your median nerve, the one which are on the lateral side, median nerve, and then the lumbrical number 3 and 4, these 2 will be supplied actually by the ulnar nerve. Ulnar nerve there, guys. Okay. So that is the information that you people already know. Now don't worry about that. ये तो आपको already पता है. Now the main thing which is mostly asked in the AIMS exam, I'll tell you, that is about the interossei. That is your palmar interossei and dorsal interossei. See, the moment you look at this diagram on the screen, there are like 2 diagrams there. Okay. And in one of the diagram you can see the muscles are like unipinnate. So the one which are unipinnate will be your palmar. The one which are unipinnate will be the palmar interossei, and the one which are bipinnate will be the dorsal. They are like dorsal interossei. Okay. The one which are unipinnate, actually the moment you look at the diagram there, those muscles are actually present between the bones only. So between the bones, that is interossei, in between the bones, but the one which is unipinnate will be actually the palmar interossei, and the one which is bipinnate will be the dorsal interossei. Dorsal interossei, guys. Fine. Now we all know the action of this one. The palmar interossei is the one which will be actually helping in adduction of the fingers, the very famous mnemonic pad. It will be actually helping in adduction of the fingers over there. Okay. And then dorsal interossei is the one, which will be actually helping in taking the fingers away, and this is actually, yes, the mnemonic that is used for that one will be your dab. Okay, dorsal interossei, the mnemonic that is used will be actually dab there, guys. Okay. So palmar interossei will be helping in bringing all the fingers closer, and dorsal interossei is the one which is helping in taking the fingers away from there. So palmar interossei pad and dorsal interossei dab. Fine. Now all this is like basic information. Now what is your AIMS exam and INSET exam concerned about? The AIMS exam and INSET exam, they are concerned about, yes, look at that middle finger here, guys. look at the middle finger here. Now middle finger, now if you just see the origin and insertion of the palmar interossei and dorsal interossei, the first palmar interossei is actually getting inserted over here. The second palmar interossei is actually getting inserted over here. And the third palmar interossei, it is the one which is getting inserted here onto this finger, and the fourth one that is getting inserted over here. So if you are observing carefully this diagram, in this diagram, that's the middle finger over there, and middle finger doesn't have any palmar interossei. So there is no palmar interossei on the middle finger. There is no palmar interossei attached onto the middle finger, already asked in the exam. Exactly contrary to that one, opposite of that one, guys. If you look at a dorsal interossei, you can see this is the first one, the second one, and the third one, and the fourth one. There are 4 dorsal interossei, and out of that 4, remember, even the second as well as the third one, both the dorsal interossei are inserted onto the middle finger there, guys. Understanding? So therefore, middle finger is the one which is actually having 2 dorsal interossei attached to that one. So there are no palmar interossei in the middle finger, but there are 2 dorsal interossei attached to that one. There are 2 dorsal interossei attached to this one here. So this is something like very much important. Fine. So on the middle finger there will be no palmar interossei attached to that one, but on the same middle finger there will be like two dorsal interossei attached. Okay. So this is what is something very much important. Now why I am concerned about this one, why I want you to remember this one here, my dear friends, remember, yes, for this question over here, guys. Look at that beautiful diagram on the screen there. Recently in 2019 and even 2020, most of the time they're even giving you the cadaveric images. All the textbook images and all those line diagrams, that's an old thing nowadays. Nowadays they are giving like cadaveric images. There was this cadaveric image given in the exam, and yes, they have marked, there was an arrow marked onto the middle finger. You can clearly appreciate that it is the dorsum of the hand there, and that is the middle finger arrow marked. And then they have asked like which tendons are actually getting inserted over there. Options were given, like out of all these tendons, which tendon is getting inserted over there. So now to understand or to answer this question in your AIMS exam or INSET exam, you should actually have the knowledge of all the insertion of these muscles whichever I have showed you there, guys. Okay. Now first of all, let me just take that out here. For example, it is the same middle finger there. Okay, it is the same middle finger there, guys, and now this one here, this one over here is actually the extensor digitorum tendon. This is extensor digitorum tendon. This is extensor digitorum tendon over here, without any doubt. For extending all the 4 digits there, we will be actually having a muscle here, extensor digitorum, that is a tendon. Now just recall, I told you very clearly the middle finger will have how many interossei? The middle finger has got like how many interossei attached to that one? There will be 2 interossei. Which 2 interossei? Which 2 interossei? The 2 dorsal interossei, the second one and the third one. You can clearly appreciate in my diagram over here, the second and the third, these 2 dorsal interossei are getting inserted onto the, yes, dorsal extensor hood there, guys. Okay, dorsal digital expansion, that is nothing but the extensor hood over there. So there it is actually getting inserted. That is one thing. And not only that, the most important thing, appreciate one more thing, lumbrical here. And which lumbrical, guys? Can you see the second one here? Even the second lumbrical, if you follow the tendon of that one, the tendon will actually be going back and yes, inserting along with the extensor digitorum tendon, guys. Okay, so lumbrical number 2, and then the second and the third dorsal interossei, but no palmar interossei. So all of them are merging at the dorsal digital expansion. Okay, fine. So this is the extensor digitorum tendon over here, and after that, this one that you are able to see here, and this one that you are able to see here, that's your dorsal interossei. Dorsal interossei, the second one and the third one. Okay, dorsal interossei, and this muscle or this tendon that you are able to appreciate here, that's your lumbrical. And which lumbrical is that one, guys? That is your second lumbrical. So that is your second lumbrical over there, the second dorsal interossei and third dorsal interossei. And that was the question asked in the exam. Just try to understand the standard there, guys. So most of the time during your first year MBBS days, okay, and for other exams you'll be just learning about the 20 muscles of hand. But your AIMS exam, what I am trying to put in your mind is that before going to the exam, you actually have to revise this concept here. They are concerned about, always they are concerned about the attachments of the 20 muscles of hand. Attachments of 20 muscles of hand, sir. Okay. So therefore, just to conclude again here, number one, you have to remember extensor digitorum. And number two that you have to remember is the second lumbrical here. And number three that you have to remember is the second dorsal interossei. And number four that you have to remember is the third dorsal interossei. No. Okay, Sharma, it is not like two lumbricals there. There are two dorsal interossei I told you, the second and third. Only second lumbrical I told you, not two lumbricals, second lumbrical. Okay. It is not two lumbrical, it is actually second lumbrical. Second lumbrical, guys, okay. That is actually the second lumbrical, Sharma. It is not the two lumbricals over there. Fine here. Any more doubts? Any more doubts, guys? I hope now your doubt is clear there, Sharma. Yes, very good, fine. So I repeat again, if you still have any doubt there, one is the extensor digitorum tendon, and then the second lumbrical coming and getting inserted there, and then the second and third dorsal interossei is coming on, getting attached there, guys. So all these are the one which are getting attached onto the dorsum of the middle finger over there. So attachments is important here. Done. Now welcome back. I'll tell you like one more question which was recently asked in the exam. Yes. The diagram given, and in this diagram the question that was given was, at this arrow marked region, what is the muscle getting inserted? At this arrow marked region, what is the muscle getting inserted? So I hope you're understanding that. Again, they're asking about the insertion. This was asked in INI SET exam 2020. But there is a slight bit of confusion among the students. Some of the students told that the arrow mark was at the shaft of the first metacarpal. Or some students have told that the arrow mark was at the base of the first metacarpal. Okay. Some students, yeah, I'm really happy there. Prithviraj is actually telling about the opponent's policies there. But yes, Prithviraj, you have to be like really careful whether the arrow mark is at the shaft or at the base of the first metacarpal. So let us do one thing here. Let us discuss all the origins and insertion over there, and then we can move ahead, guys. So it is not about only learning the names of all the 20 muscles here. So you have to actually learn about the attachments here. Now first of all, my dear doctors, remember, in this thumb you are able to see a distal phalange, and in this distal phalange there will be one muscle getting inserted over here. There is one muscle getting inserted over here into the distal phalange. Obviously, what should be that muscle? That muscle has to be the flexor. And if that tendon is going all the way up to distal phalange, definitely it should be this tendon there. It should be your flexor pollicis longus tendon. Definitely it should be the flexor pollicis longus tendon, guys. Okay. Flexor pollicis longus tendon is the one which is getting inserted there onto the distal phalange. Now after that, yes, welcome to the proximal phalanx. There. Now on this proximal phalanx, this is the point where your thenar muscles are going to get inserted there, guys. Which muscles? Thenar muscles are going to get inserted there. Insertion, not origin, insertion. So which thenar muscles will be getting inserted there? In thenar group of muscle, I hope you all remember the names there. At this point of time, I don't have to teach you the names now. So one will be the flexor pollicis brevis muscle, and another one will be the abductor pollicis brevis muscle. So flexor pollicis brevis and the abductor pollicis brevis, both of them are getting inserted onto the proximal phalanx. So you can remember very simply, I'll tell you one simple logic here. In the name itself, you are actually having the name as brevis there, guys. That is brevis. And what is the meaning of brevis? Brevis means short. The muscle is very much shorter in length. Longus means it is very long. Longus, the muscle is very much longer, whereas brevis is actually very much shorter. And because it is shorter, remember one simple point there. It cannot go beyond the proximal phalanx. Easy to remember for your exam. Thenar group of muscle, or whether it is hypothenar group of muscle, they will actually go and get inserted only onto the proximal phalanx. They cannot go beyond the proximal phalanx there, guys. Okay, so that is why flexor pollicis brevis, abductor pollicis brevis are inserted onto the proximal phalanx. Done. Next one. What about the muscle inserted onto the metacarpal? Yes, this was a question asked in the exam. The muscle inserted onto this metacarpal over here will be your opponent's pollicis, guys. Here it will be opponent's pollicis. There it will be actually opponent's pollicis there, guys. And it makes sense why the opponent's pollicis is getting inserted onto this metacarpal over here. Why? Because, yes, for opponents, like for opposition, the thumb actually has to move completely like this. Okay, and then, oppose the fingers like this. So it's not about the distal phalanx or proximal phalanx. It is not the movement of this one. The entire thumb, like metacarpal, has to move like this, and then it has to oppose the fingers. And that is the reason why the metacarpal itself has to move. So opponent's pollicis, remember, it is the one getting inserted onto the shaft. Then what about the base? Yes, this was the confusion, as I told you. This was the question given in the INA set, guys, recently. And this was the confusion. Some of the students have recalled that the arrow mark was on the shaft. Some of the students have recalled that the arrow mark was on the base. So if it is marked at the base, remember, it will be actually the abductor pollicis longus. Abductor pollicis longus muscle, which is actually a muscle of your forearm, and from there the tendon will come and get inserted onto the base of the first metacarpal. The base of the first metacarpal, there it is getting inserted. That is abductor pollicis longus. Now next one here. The next thing, like whatever this red colored mark that you are able to see here, that is a standard notation in our anatomy books there, guys. Okay. Okay. So in our standard anatomy representation, red color is actually for origin and the blue color is actually for the insertion there, guys. So whatever this red color is given there, that is actually the origin of your first interossei, that is your palmar interossei. The first palmar interossei will be originating from there. So that's a simple thing, but I want you to remember these three things, all these insertions and origin from the of the thinner group of muscles, guys, on your thumb over here. Done. So basically, when you are preparing for your INA set exam, remember, it's not about learning just the 20 muscles in the hand. It's all about their attachments nowadays. So that is our concept number one. I told you about their attachments of the muscles here. I hope it is very, very clear to you people, guys. Okay. So basically what I'm trying to put in your mind is that, yes, you have to go to the exam learning the attachments of muscles of hands, or all the 20 muscles of hand, the attachment you have to be perfect. Fine. Now once you are done with this one, let us go to the next concept, sir. Concept number 2 here. Let's go to the second concept over here. Now in the concept number 2, the second concept, I want you to learn about the cubital fossa. Cubital fossa, okay. So I'm actually going like topic by topic wise, guys. So first we'll be doing like upper limb, then we'll do the thorax topic, then we'll do the most important one, neuroanatomy and even head and neck also. Then later on we are also going to discuss about a few topics in histology, embryology and also on. Now why did I give you this image here? Again the same thing, cadaveric image, and I think in 2019 AIMS exam, they were in the same exam, there were 2 questions given only on the cubital fossa. There were 2 questions given only on the cubital fossa only, and that too cadaveric image was given. So let us try to identify all the structures here. I hope every medical student remembers that in the cubital fossa, yes, the content of the cubital fossa is very much important here, and the content of the cubital fossa you can remember easily with the mnemonic as MBBS. Now in this MBBS, what is this MBBS, guys? M stands for the nerve, that is your median nerve here. So first of all, try to identify in this diagram here, yes, this one here will be the median nerve. So this one here will be actually the median nerve. Fine. Then apart from that median nerve, guys, the next thing that you have to remember here is the artery. This is actually the brachial artery, later to that one. Fine. That is the brachial artery. You can easily follow. Never ever try to just look at that part of the diagram and finalize the things over there. Always try to see the proximal part and distal part, guys. If you just follow this brachial artery distally here, you can clearly see it divides into the radial artery and the ulnar artery there. So brachial artery as well as even the branches of the brachial artery are the contents of your cubital fossa. Then once you are done with this one here, this muscle here, this is actually the biceps brachii muscle. biceps brachii muscle and its tendon. Biceps brachii muscle and its tendon over here, guys. That is the one thing. And then the radial nerve. So I'm just writing again here only. So B stands for the biceps brachii tendon, biceps brachii tendon, and then finally this one here will be actually the radial nerve. And which branch of the radial nerve? Remember, it is not which branch of the radial nerve, guys? It is not the deep branch. Remember, it is the superficial branch. So it is superficial branch of the radial nerve. That is the reason why people tend to remember that as MBBS, the median nerve, the brachial artery and branches, the biceps brachii tendon, and then the radial nerve. That is the superficial branch of the radial nerve, guys. Now, once you are done with this one here, yes, my dear friends, someone is asking this, or how to identify which is lateral and medial epicondyle. It is very simple. Out of the lateral and medial epicondyle, remember, medial epicondyle is the one which will be like more prominent over here. This is the medial epicondyle, more prominent. One thing to identify. Second thing to identify, which is like lateral and medial, it's very easy. On the lateral side, you'll be actually having a big bulky muscle over here, and that's your brachioradialis muscle. So on the lateral side, you'll be actually having the brachioradialis muscle. Okay, and whereas on the medial side, you'll be actually having the pronator teres muscle, guys. On the medial side, you'll be actually having pronator teres muscle. So on the lateral side, you'll be having brachioradialis, a thick bulky muscle over there. You can easily identify that one. And on the medial side, you'll be actually having the on the medial side, you will be actually having the pronator teres muscle there, guys. Okay, that's the way how you will be easily able to identify the lateral and medial aspect. Lateral and medial aspect here, guys. Understanding my point here? Chaliye, badhiya. Okay. Okay. No. Siddharth, ulnar nerve. Siddharth, that is actually the biggest mistake there. Remember, Siddharth, ulnar nerve is not at all the content of the cubital fossa there. Ulnar nerve is not at all the content of the cubital fossa there, guys. No. Okay. Why? Because I'll tell you very clearly, Siddharth, ulnar nerve is the one which is actually going to pass behind the medial epicondyle. Ulnar nerve is the one which is going to pass behind the medial epicondyle. So it is not at all a content of your, cubital fossa. It cannot come in the cubital fossa there. In cubital fossa, the content will be MBBS here, guys. Only the median nerve and the brachial artery and its branches, biceps brachii tendon, and then the superficial branch of the radial nerve, guys. Okay. So yes, very good, Prithviraj. Fine. That is the content of the cubital fossa. And remember that in AIMS exam 2019, it has been given twice there in the exam. In the same exam, 2 times the question was given about cubital fossa. Now I'll tell you one more thing here, guys. I'll tell you one more thing here. It is not about cubital fossa. At this point, don't think that why is Dr. Azam telling such a simple topic. We all know from first year MBBS, it is like, the content is MBBS. But what they are doing is, I'll tell you what was the question exactly. In the exam, the question was not about cubital fossa. In this cubital fossa, they have actually marked median nerve. Okay. They have actually marked this nerve as median nerve. For example, it has been marked like something X. And what they have given is, if this nerve which is marked as X, if it is injured, then what will be the loss of sensation in the hand? Understanding? So if that nerve is injured, then where will be the loss of sensation in the hand? So that was the question given. So don't think that such a simple question is given in INA set. No, it is not like that. Actually, the thing is that they have given cubital fossa diagram, in that the nerve marked was the median nerve, and median nerve injury leads to which? Loss of sensation. That was the question. And one more question was, they have marked the radial nerve, and if radial nerve is injured, then what will be the consequences? There will be like, there are options given like a wrist drop, flat shoulder, so and so like that. So my intention is not about teaching you a simple topic here at this point of time. Cubital fossa, if you are able to identify that, then you have to apply the injuries to that particular nerve. So if there is median nerve injury, then what is going to happen? And then similarly, if there is an injury to the radial nerve, then what is going to happen? So these kind of questions were actually given in the INS exam, guys. Okay. So that is why I have included this here in the concept number 2 about the cubital fossa. Fine. Now let's move on to the concept number 3. Now let's move on to the concept number 3 here, sir. The concept number 3 here deals with actually the next one, that is your femur. Oh my god, we can't actually go to the ionized exam. We cannot go to the ionized exam, my dear friends. We cannot actually go to the ionized exam without learning the attachments of femur. It has been like continuously given in the exam, and you should be like crystal clear which muscle is attached where, and that too what will be the function of that muscle, guys. What is the function of the muscle? Important. I'll tell you one simple logic here. For example, the moment I ask you, like for example, gluteus maximus muscle, what is the action of that one? Can anyone tell me? I am looking there in the chat box there, guys. If gluteus maximus muscle is given to you, and what is the action of the gluteus maximus muscle? Can anyone tell me? Can anyone tell me what is the action of the gluteus maximus muscle? Hello? स्टॉप हो गया, स्टॉप कर दिया, स्टॉप किया क्या? Hello my dear friends, welcome back right now. So there was a small technical glitch here, and now after that we are actually going to continue further, so with all the concepts now. So guys, like I actually told you about the previous things, like the previous two concepts that I told you. One is about the muscles and their attachments into the muscles of hand and their attachments. And the second thing that I want you to know about is the cubital fossa. But in cubital fossa, it's not about the only topic of cubital fossa over there, guys. The contents of that, and the contents of that, the nerves are very much important. If the particular nerve is damaged, then like what is going to happen? The consequences we can see. Now the third concept that I want you all to study for your ionized exam is actually about the attachments onto the femur bone. This is like one of the hot favorite topic for AIMS and ionized, guys. One of the hot favorite topic for the AIMS and ionized. So we got to learn this. They have given like n number of times the attachment onto the femur. Now the moment the diagram is given in your exam, the first thing that you have to understand here is like which is the view here. Is it like anterior view or the posterior view? Now if you look at this diagram here, first of all, this is actually the anterior view of the femur, sir. Now how can we identify the anterior view and the posterior view of the femur separately? Now remember, in the anterior view, between the greater trochanter and the lesser trochanter, for example, if this one here is the greater trochanter and this one here is the lesser trochanter, between them there will be intertrochanteric line actually. Between them there will be just an intertrochanteric line. Be careful about that one. So in the anterior view, you will just have that intertrochanteric line. Perfect. Whereas when you see the posterior view, in the posterior view you are able to clearly observe there the crest. There will be intertrochanteric crest. So between the two, that is your greater trochanter and lesser trochanter, you will be actually having the intertrochanteric crest. So anteriorly you will be actually having the intertrochanteric line, and whereas the posteriorly there will be a crest clearly visible. And second important thing, how you are able to identify here will be the lesser trochanter will be very much prominent here. When you see in the posterior view, the lesser trochanter will be like more prominent or very clearly visible, we can say. Very clearly or completely visible, lesser trochanter. Now once you have identified the anterior view and the posterior view of the femur, now the next thing is, let us actually see the attachments of the muscles onto this one here. The muscles getting inserted onto this one will be the gluteus muscles. Now first thing, onto the greater trochanter. Which muscles are going to get inserted onto the greater trochanter? Onto the greater trochanter you will be actually having two of them, gluteus medius and minimus, but I want you to remember in more depth. Remember, gluteus minimus is the one which will be inserted onto the greater trochanter, but more on the anterior surface of that one. Okay. So on the anterior surface, it will be actually the gluteus minimus, whereas onto the posterior surface, you will be actually having the insertion of gluteus medius actually. So we know that gluteus minimus and gluteus medius and minimus, both of them are inserted onto the greater trochanter only, but minimus will be inserted onto the anterior surface of that one and medius onto the posterior surface. One thing is very clear. Then sir, what about the maximus? Remember, that was the thing which was given in the exam. So in the posterior view, you will be able to actually see the linea aspera there, and linea aspera on the upper aspect, it is actually dividing. And here you will be able to find the gluteal tuberosity. And onto this gluteal tuberosity, what is going to happen, sir? There will be insertion of gluteus maximus. I repeat the term again, that is gluteal tuberosity. One thing I want to make it very clear, don't think that the entire gluteus maximus muscle is getting inserted onto the tuberosity there. No, a part or some of the fibers are also getting inserted onto the iliotibial tract also. So some of the fibers are inserting onto the gluteal tuberosity, and some of the fibers are getting inserted onto the iliotibial tract. Iliotibial tract, sir. Fine. Next one. So once you are done with the gluteus medius and gluteus minimus and maximus, now the most important thing, why I am actually teaching you this one here. This you might have studied in even in your first year MBBS also, and you might have studied during the preparation for your INA set or NEET PG or FMG, whatever it is. Insertions and the attachments, I think you have already studied about this. But in 2020 INA set exam, they have given about the actions of gluteus maximus. So that is the time when there was some technical problem there, and we need to stop the class in the middle there, guys. So now again I am asking you the same question. Can anyone tell me what is the action of gluteus maximus muscle? What is the action of gluteus maximus muscle? Can anyone tell me what is the action of gluteus maximus muscle? Recently it was asked in your INA set, guys, last exam only. Can anyone help me out? Most of the students during the live classes will be answering that gluteus maximus, the largest muscle in our body, will be actually helping in extension at the hip joint. So right now, for example, yes, extension, very good. So most of the students will be answering as extension at the hip joint. I am really happy with that one. Right now you are sitting there, I am sitting here, and our hip joint is actually flexed, and from this flexed position, suppose I am standing up, what is going to happen? Extension will occur. That is fine, but that was not the only answer in INA set. So it is not like your simple exams there, guys. It is INI set, and there in that option, what about the action of gluteus maximus? Okay. Look here. Number one, gluteus maximus will be helping in extension at the hip joint. Okay, extension of the flexed thigh. For example, right now in a sitting position, it is flexed, and from a sitting position, if you are standing up, that is nothing but extension from the flexed position. Number one function. And number two, my dear friends, remember, yes, it is also actually helping in the lateral rotation of the thigh. Gluteus maximus is also helping in lateral rotation of the thigh, and its upper fibers are actively helping in abduction of the thigh also. Oh my God. So please update that in your notes. Please update that in your notes. Gluteus maximus is not only helping in extension at the hip joint, along with extension, it is also a very good, a strong lateral rotation. It is helping in lateral rotation, as well as it is also a very, very good abductor also. So abduction also. And yes, in one of the option it was given. So students, what I am trying to tell you is that in the examination hall, students were comfortable about that extension, but the problem was with the lateral rotation and abduction. So most of the time the students will be learning only about the extension, but along with that, remember the lateral rotation as well as the abduction also is the function of gluteus maximus. Perfect. That is one thing I want you to update in your knowledge, in your books there. Number two, then what is the function of these two, guys? Gluteus minimus and gluteus medius. Gluteus minimus and medius, I think you people are like experts in that one. These two muscles are the one which will be actually helping in abduction at the hip joint. Hope you remember the correlation of this one with the Trendelenburg sign and all. So that is actually helping in abduction. But again the same thing, please update there in your books. Both gluteus medius and minimus will be helping in abduction of thigh, Not only abduction of the thigh, the anterior fibers will help in medial rotation also. So, therefore, medius and minimus, these two will be helping in abduction as well as the medial rotation. Abduction as well as the medial rotation also, guys. Abduction as well as medial rotation. Very good, Dr. Ramya. Very good, Dr. Saran. Very nice. Okay, na? Yes, very good, Dr. Sriram. Very nice. Okay, so that is what I wanted you to update in your books there, guys. So, attachment is done. Attachment of the muscles is done. Their action is done. Everything has been done here, guys, in a crystal clear manner. Now, what is left out here? We are left out with the lesser trochanter. And now, what is getting inserted onto this lesser trochanter here? Again, insertion. Therefore, I am using the blue color there, guys. Yes, again on the lesser trochanter, there will be insertion of iliacus muscle as well as the psoas major muscle. On the lesser trochanter, there will be insertion of the iliacus as well as the psoas major muscle. And in some of the books, they will also refer this as the iliopsoas muscle. Iliopsoas muscle will be inserted onto the lesser trochanter. Done. And you are not going to go to the exam without learning about the attachments onto the femur, guys. Attachments on the femur, very much important, very much important. You have to learn that one. Next one. Now, welcome to the next concept, concept number 4. Are you all comfortable with this one here? Just give me a thumbs up, guys. I hope now it is perfectly right. After a small gap in the middle, I hope everything is perfect. Now, welcome to the next concept here, sir. Concept number 4 there, guys. Now, in the concept number 4, yes, that is the cadaveric image of the heart that was already given in the exam. And in this image, we have to actually understand like what will be the blood vessels present over there. And I will tell you at the end of this concept, the question how they are asking in the AIMS exam, guys. In mostly like last 2 to 3 years exams, okay, like 2019, 20 and all, how they have tested in the exam, I'll let you know, guys. Okay. First of all, we all have a habit of learning with this diagram. Yeah? Always we actually have a habit of learning with the help of this diagram. Now, in this diagram, we all know this will be the right atrium here, and this will be the right ventricle over here, and this here will be the left ventricle, guys. Perfect. And this artery that you are able to appreciate here, this is the right coronary artery, and that right coronary artery will actually take a turn, and it is going to give a branch over here. That branch is PIVA, that is posterior interventricular artery. And not only that, along with this margin, it is also going to give rise to a marginal artery also. Marginal artery. So, this right marginal artery and the posterior interventricular artery, these two will be the branches of right coronary artery only, no problem. Now, this one is your left coronary artery over here. It is very much shorter in the length, and immediately it is going to divide into 2 branches over here. One will be the circumflex artery, which is going to take a turn, and this one here will be the AIVA, anterior interventricular artery. And the same anterior interventricular artery, it is also known as very famously known as the LAD artery, left anterior descending artery, left anterior descending artery. Fine. Now, let us do one thing. First of all, in this diagram, let's try to appreciate the same things. All those structures, let us try to appreciate them here. Now, my dear doctors, remember in this diagram, this one is your right atrium over here, without any doubt, and this one here will be the right ventricle, and this one here will be the left ventricle. So, it is not exactly in the anatomical position, it is little bit more turned in the front. Left ventricle is more visible over here in this diagram. Fine. Apart from that, this one here will be the ascending aorta. This is ascending aorta over here, guys. And this here will be the pulmonary trunk. There is a pulmonary trunk, guys. Ascending aorta and pulmonary trunk there. Fine. And now, the moment you see that right atrium and right ventricle is present over there, no doubt this artery here will be the right coronary artery, guys. This artery here will be the right coronary artery. And that, if that is your right coronary artery over there, it is going to take a turn and then go back. I told you it is going to give rise to PIVA, posterior interventricular artery. So, remember, this one here will be the marginal artery. This is marginal artery over here. Of course, the right marginal artery, also known as the acute artery. Then what about the remaining branches? Yes, obviously, left coronary artery you will not be able to appreciate in this diagram. Why? Why? Because sir, you can clearly see in this diagram here, left coronary artery is the one which is going to pass behind the pulmonary trunk there. So, you will not be able to see the left coronary artery in this diagram here. Now in this diagram, this one here will be the anterior interventricular artery, or very famously it is the one which is known as your LAD artery. Anterior interventricular artery, which is also known as the LAD artery, guys. LAD artery. Now the one which is going to take a turn from here, this one here will be nothing but your circumflex artery. This is the circumflex artery here. Fine. Now after identifying these branches over here, now let me tell you about one most important one which was recently asked in the exam, that is diagonal branch. I'm actually seeing in the chat box over here, guys. Can anyone tell me diagonal branch or diagonal artery, it is a branch of which artery? First of all, tell me one thing here, diagonal branch is a branch of which artery actually? Diagonal artery or the diagonal branch is a branch of which artery? Okay, I'll first show you in this textbook diagram here in the atlas image there, then afterwards we'll come back to the cadaveric image. So in this diagram, my dear friend, you are able to appreciate here, this one here will be a diagonal branch. This one here will be the diagonal branch here, guys. Perfect. So diagonal branch, actually it is a branch of your LAD. I'm really happy with that one. It is a branch of your LAD, fine. But in your exam, the question was, it will be supplying to which chamber of the heart, whether it is right atrium, right ventricle or left ventricle. We can clearly see the direction over there. The diagonal branch is a branch of LAD and it is going there, and it will be definitely supplying to which chamber of the heart, sir? The left ventricle. So the same thing you can even appreciate in this diagram also. So in this diagram here, this one here will be the diagonal artery, and diagonal branch is the one which will be supplying to which chamber of the heart? Without any doubt, it will be supplying to the left ventricle. Hope you are able to compare the textbook wala diagram, that is atlas image, with the cadaveric image, and this image was actually given in the exam. Fine. Now once you are done with this concept here, sir, let us move on to the next concept here. In the next concept, welcome to another very favorite topic of AIIMS examiner, another hot favorite topic of AIIMS examiner, that is about the development of interventricular septum. Development of interventricular septum. Fine. Remember, interventricular septum is actually formed by three parts. One is the muscular part, another one is the membranous part, and then another one will be the bulbar part. I repeat again the three parts here. I hope you have learned about that. Muscular part, membranous part and bulbar part. Out of that, yes, in many of the exams they have actually given a gross diagram. I mean to say, the diagram was given about the gross anatomy of the heart, but the question was from the embryology. So for example, if this is the internal structure of the heart over here, in this internal structure of the heart, this was marked, and this structure is derived from where? Okay, so before I tell you, yes, try to answer guys, what is that part first of all? Remember, that is actually the membranous part of the interventricular septum. That is a membranous part of the interventricular septum, and then this one here will be actually the muscular part. This is the muscular part of the interventricular septum, guys. So membranous part and then muscular part. So we need to now learn what is this derived from. Muscular part is very much easier, guys. Muscular part is very much easier, sir. Okay. So muscular part is actually the one which will be derived from where? From the cardiac muscles only. Cardiac muscles only. So when you learn about the embryology part, yes, what is going to happen, guys? The muscles in the wall of the ventricle, that muscle itself will be actually giving you the evagination there. That is nothing but the cardiac muscle, and cardiac muscle is the one which is going to form the muscular part. Done, no doubt about that. Then what about this membranous part? Remember, membranous part is the one which will be derived from the endocardial cushion. It is contributed by endocardial cushion. Endocardial cushion. And finally above, what do you have there, guys? One more part, that is a bulbar part, or we can say bulbar septum. So bulbar part or bulbar septum, this is the one which is present over there above, and that is the one which will be derived from neural crest cells. We can't see that bulbar part over here in this diagram. We cannot appreciate that one, guys. It is further above, and that bulbar septum or the bulbar part is derived from the neural crest cells. Okay. Now Avinash is actually asking about the aorticopulmonary septum. Avinash, I'll let you know about that. Just wait for a few seconds there. First, let us finish off about the development of interventricular septum, guys. So interventricular septum, it's a very easy topic. Only and only your focus should be on three parts here, sir. Only three parts. So what are the three parts of interventricular septum? The muscular part, membranous part, and the bulbar part. Bulbar part is derived from neural crest cells. Muscular part is derived from the cardiac muscle, and the membranous part is the one which is derived from the endocardial cushion. Endocardial cushion. Done. Next one. So I hope it is very much clear here. Now moving to the next concept, concept number 6 over here. The concept number 6, I kept it as development of the heart because it has been asked like many times in the AIMS exam, guys, about the development of the heart. And yes, Avinash, your doubt will be clarified here, guys. Okay. Yes, of course, Sharma, it is the uppermost part there. Now in the development of the heart, I hope you have seen there will be two heart tubes, and those two heart tubes are fused cranially. There will be two heart tubes and they are fused cranially. Fine. And then in that heart tube there will be actually the three dilatations present there, guys. Okay. There will be like three dilatations in that one. Now remember, in this the cranial most part will be the truncus arteriosus. The cranial most part will be the truncus arteriosus, and the caudal most part here will be the sinus venosus. First you learn this terminology, guys. The cranial part, upper part will be the truncus arteriosus, and the caudal part will be the sinus venosus. From the name itself we can understand venosus, venous, it is the one which is going to drain the blood. So from there what is going to happen? The blood is going to enter inside, and truncus arteriosus is the one from where the blood will be actually moving out. It is going to move out from there. So that is the outflow part. So because it is the outflow part, that is the most important hint I am telling you. That is a catch there. That is a key word there. So because truncus arteriosus is actually the outflow, it is the outflow part there. That is the reason, my dear friends, remember, truncus arteriosus is the one which is going to form, yes, the aorta, ascending aorta. It is the one which is going to form the ascending aorta. And not only ascending aorta, even the pulmonary trunk. You can compare this embryology easily with the gross anatomy, guys. Compare this embryology with the gross anatomy right now. So right now in your body and my body, in your heart and my heart, yes, what is the one which is going to take the blood out? The blood is taken out via the ascending aorta as well as the pulmonary trunk. So ascending aorta and the pulmonary trunk are the one which are going to take the blood out. So that is why they are actually derived from the truncus arteriosus part. And what about the one which is going to drain the blood? Drain the blood in the heart will be the coronary sinus. And remember, coronary sinus has to definitely develop from the sinus venosus. But I told you very clearly, the sinus venosus part, it is not like completely fused there. It is free. So because it is free, it will be having like two horns here. One will be the right horn, another one is the left horn. Now out of this right horn and left horn, can anyone tell me which is the one which is going to form the coronary sinus? Is it the right horn or left horn? Can anyone tell me here, guys, whether it is the right horn or the left horn, which is the one which is going to form the coronary sinus? Remember, it is the left horn. Left horn, the remnant of that will be the coronary sinus. The remnant of that one will be the coronary sinus there is. Okay. Now coming to the doubt that has been asked by Avinash over there. Yes, Avinash, let us do one thing here. What is this dilatation here known as? The dilatation here is actually the bulbus cordis. The dilatation here will be the bulbus cordis. And bulbus cordis is the one which will be actually divided to how many parts? Three parts. Bulbus cordis will be divided to how many parts? Three parts. The one which you are able to see, the cranial most, truncus arteriosus. And then just behind that, this one here will be the conus. And then we can just write down this part here as the proximal 1/3. No specific name to that one. It is just the 1/3. So bulbus cordis is the one which is actually having three parts there, truncus arteriosus, and then the conus and the proximal 1/3, guys. Now you yourself can easily decide here. Now what is this part here, sir? Truncus arteriosus is going to form what? Truncus arteriosus is the one which is going to form ascending aorta and pulmonary trunk. Fine. But how come it is divided? If a simple question comes in my mind, okay, how these two are separated? Yes, with the help of a septum. So So let me just enlarge this one here. So for example, if this one is a truncus arteriosus, inside the truncus arteriosus you will be able to appreciate one septum there, and that septum will be actually the aorticopulmonary septum. So for example, on one side you are able to appreciate the ascending aorta over here, and on the other side there will be actually the pulmonary trunk. That is the reason why the septum in the middle is actually referred to as aorticopulmonary septum, or else it is also known as the spiral septum. So this one will be the aorticopulmonary septum, or else it is also known as the spiral septum. I hope you are getting it right now, Avinash. And remember, Avinash, one more important thing, from where it is derived. Remember, aorticopulmonary septum is the one which is derived again from neural crest cells only. Neural crest cells only. Now try to understand that just beneath this truncus arteriosus, what do you have here, sir? We'll be having the conus part. And conus is the part which is actually going to form the smooth outflowing part of the ventricle, that is infundibulum part. So if it is infundibulum part, there what is going to happen between the two ventricles? There will be interventricular septum. And yes, here you will be able to understand, yes, that is actually which septum here, guys? That will be actually the bulbar septum. So as I told you here, you will be actually having the ventricles, and in the ventricle there will be interventricular septum. Interventricular septum has got three parts, the muscular part, and then the membranous part, and the bulbar part, or the bulbar septum. So that bulbar septum is also derived from where only? The neural crest cells. Okay, neural crest cells. Okay, so my dear friends, remember actually what is going to happen? Actually what is going to happen is that the truncus arteriosus part will have a septum in the middle, that is the spiral septum, and then the conus part will actually have a septum in the middle, that is the bulbar septum. And these two septum, both of them are derived from where only? Neural crest cells and neural crest cells only. That is actually the continuation of that one only. Okay, so these two together, that is the aorticopulmonary septum and bulbar septum, these two septum together, it is actually referred to as the conotruncal septum. Conus part and the truncus arteriosus part. So conotruncal septum, guys, and that was actually asked in your exam. Conotruncal septum was the one which is actually asked in the exam, guys. Okay, so what is this conotruncal septum? Conotruncal septum is nothing but bulbar septum plus aorticopulmonary septum. Bulbar septum plus spiral septum, these two together will be nothing but the conotruncal septum, because it is in the conus part as well as the truncus arteriosus wala part. Perfect. Is it okay? And the final answer here, the conotruncal septum is also derived from where only? If there is a question in the exam, okay, conotruncal septum is derived from where? So remember, conotruncal septum is also derived from the neural crest cells only. Is it okay? So that's really important, guys. Okay. MacDoc is telling, sir, please repeat, where is the infundibulum? Infundibulum is actually the smooth outflowing part of the ventricle, guys. Infundibulum is actually the smooth outflowing part of the ventricle only. Okay, so infundibulum is actually the smooth outflowing part of the ventricle. I don't have a diagram for that right now. Most of you might be knowing already. So the smooth outflowing part, that is infundibulum, will continue up into the aorta, ascending aorta, and the pulmonary trunk only. So it's like a continuation there, guys. Is it okay? So this is another important concept to be learned for your exam, for your INA static exam, guys. So development of interventricular septum and then development of heart. Many questions will be asked from here. Please take care about that one. Now once you are done with this one, let's go to the next concept, concept number 7. And in the concept number 7, it's about the kidneys here. Now sir, why did I include this one over here? Why? Because in the kidney, in the topic of kidney, they are actually interested about the relations of that. So recently it was given. And why I am showing you here the cadaveric image? Why? Because in your exam, it was the cadaveric image of the kidney given, and the question was, what is related to this star marked region here, or arrow marked, whatever it is. So what is related to this arrow marked region over here? So before I teach you, can anyone tell me what is related to this arrow marked region over here, guys? What is related to the arrow marked region here? Can anyone tell me what is the relation of this kidney? I am looking into the chat box here, guys. First of all, the moment you look at a diagram, I hope you're all easily able to identify, yes sir, it is actually the anterior surface of the kidney, anterior surface of the right kidney as well as the left kidney, guys. Now, if it is the anterior surface of the right and left kidney, like what are the relations of the anterior surface of the kidney? Let us do one thing here. Let me first of all make you understand this with a simple diagram here, sir. So, before going ahead with this cadaveric image and all, with the help of a simple diagram, I will tell you how to actually learn the relations of the anterior surface of the kidney. Okay. To understand the relations of anterior surface of the kidney, we'll draw a small diagram here. For example, esophagus here and the stomach here, continuing down to the duodenum. And then duodenum will further continue to jejunum, but I am not going to draw jejunum over there, guys, that long coils of jejunum and all. Now, inside this C-shaped concavity of the duodenum, you will be actually having the pancreas, and this pancreas will be going all the way. The tail of the pancreas will be in fact lying in the hilum of the spleen only. Just imagine spleen here. And now, my dear doctors, we are going to introduce the kidneys in this diagram. Okay. Now, kidneys we are going to introduce here. My dear friends, remember, where do you exactly have the kidneys? Like, what is the extent of the kidney? It is almost along with the duodenum only. How come? Remember, the right kidney will be here, and I am drawing it in dotted lines. Why? Because kidney will be present posteriorly. It is retroperitoneal, and similarly, the left kidney will be somewhere over here. A right kidney will be a little bit lower when compared to the left one there, guys. Perfect. Now, once you have this simple diagram in your mind, no one can actually stop you from answering, correctly. The right kidney and the left kidney, both the kidneys have drawn in the dotted lines. Why? Because they are present behind there, guys. Just this simple diagram, and you can easily tell the relations. How? I'll tell you. Now, let's directly do it in the cadaveric image only. First of all, the first and the easiest thing here is that both the kidneys, whether it is right kidney or left kidney, upper part of that or upper pole of that will be related to suprarenal gland only. Suprarenal gland only here also. So, upper pole of both the kidneys related to suprarenal gland only, guys. Okay. Then what about the lower part? The lower part here, my dear friends, remember the lower part here, the duodenum will actually continue to jejunum, and there will be like coils of jejunum here. So, both the kidneys will be actually related to jejunum there. And after jejunum, you will be actually having the ileum, and ileum will be going and ending into cecum from the ascending colon, and then you will be actually having the transverse colon. So, lower part of both the kidneys related to what? Jejunum also as well as colon. So, simple thing here. So, lower part of this kidney is also related to the jejunum here, the coils of jejunum, and as well as the colon, and similarly here also the lower part is related to jejunum as well as the colon part here, guys. Fine. So, till here it is absolutely same, the relations are absolutely same, whether it is for the whether it is the right kidney or the left kidney. Till here the anterior surface relations are same for right kidney as well as the left kidney, guys. Okay. Then from here onwards it will be changing. Why? Because yes, in the right kidney on the anterior surface you will be actually having duodenum taking a turn over here. So, here you will be able to see the second part of the duodenum. I am just writing it there as D2, second part of duodenum. I can even show you in this diagram over here. Hope you are able to see here. This is the second part of the duodenum which is going to take a turn in front of the right kidney, guys. Perfect. And then on the right side, what do you have there? On the right side, you will be actually having the liver, and yes, the entire surface will be actually covered with the liver, remaining entire surface. So, therefore, this will be the hepatic region here, sir. That is the place that will be covered by your liver, hepatic region. Now, whereas when it comes to the left kidney, what do you have right in front of the left kidney there, guys? There actually you will be having the spleen. This will be related to the spleen, that is your splenic area. And what is going all the way up to the spleen? Pancreas. So, this will be the pancreatic area. And then whatever is left out, that will be covered by your stomach. So, that is your gastric area, guys. That is the gastric area. That is a very simple way of remembering all the relations of anterior surface of the kidney. And the two, it was given in the it was actually given in the cadaveric image only, guys, in the exam. And what I tell you, which one was marked? Yes, this was actually marked. This area was marked here. So, this was the region which was highlighted, or it was arrow marked in your exam. It is related to what? It is related to stomach. So relations of the kidney are extremely important, already given in your exam. You have to remember about the anterior surface relations. Usually students will be actually trying to actually mug up the thing, like what are all the structures, list of structures related to the right kidney, list of structures related to the left kidney. That is the wrong way. The best way, draw a simple diagram and everything will be easier, guys. Perfect. Next one. Next, welcome to the next concept here, concept number 8. And in the concept number 8, I have included this diagram here. Why? Because, yes, another important concept here, this spine. So what is the name of this spine here, guys? I'm just writing here, the star marked. That is your ischial spine. That's the ischial spine there. And above the ischial spine, you will be able to appreciate one foramen, and that foramen will be the greater sciatic foramen. Greater sciatic foramen here. And below this, you are able to appreciate one more foramen here, sir, and this one here will be the lesser sciatic foramen. Lesser sciatic foramen, and this is the spine here, that is your ischial spine. Structures passing through the greater and lesser sciatic foramen, hope you have learned about that one. Okay, hope you have already learned about that one, guys. Now what I am interested is, what are the structures which are going to take a turn around the ischial spine? Around the ischial spine, what is going to happen? There will be a nerve, guys. There will be a nerve which is going through the greater sciatic foramen, and then it is going to take a turn and come via the lesser sciatic foramen. That is nothing but the pudendal nerve. Along with the pudendal nerve, there will be artery, and that artery is also going to go along with that one. Along with the pudendal nerve, there will be artery, internal pudendal artery, taking a turn and coming back here via the lesser sciatic foramen. And then not only that, even the internal pudendal vein also will take a turn and come back here, guys. So there will be artery, vein, and the nerve. So which nerve do you have there? That is the pudendal nerve, and then the artery and vein will be internal pudendal artery and vein. I hope you remember the very famous thing will be the very famous mnemonic here is actually your PIN, pin here, sir. PIN, pin. P stands for pudendal nerve. Pudendal nerve, and then I actually stands for your internal pudendal vessels. Internal pudendal vessels, both artery and vein are going to take a turn, and then N actually stands for nerve to obturator internus muscle. Nerve to obturator internus, all these three are going to take a turn around the ischial spine. So they are first going through the greater sciatic foramen and then taking a turn and coming out via the lesser sciatic foramen, and from there they will be actually entering into the perineum region. Okay, the pelvis and perineum region below, it will be entering down, guys. So our main intention, what is that spine? That spine is ischial spine, and the structures taking a turn around that will be the PIN. Remember that it is PIN. The pudendal nerve, internal pudendal vessels, and then the nerve to obturator internus are taking a turn there, guys. Yes, of course, Sharma, pudendal nerve block is also at the same, it is done against the same location, ischial spine only. That is why it is very much important concept here. Concept number 9, the next concept, another very favorite concept of AIIMS examiner, guys, that is fornix. Fornix has been asked a lot of times in the AIIMS exam, repeatedly in some way or the other. Whether it is like a image based question, or identifying, in whether it is sagittal section or coronal section, in like many places the fornix has been tested. Now first of all, if you observe this diagram here, in this diagram, this one here will be the hippocampus here. And hippocampus, from there what is going to happen, guys? This is the fornix here. It's going to take a turn here, and then finally it will be going and ending in the mammillary body. That is actually the mammillary body there, guys. So first you have got the hippocampus, and then the fornix going there and ending in the mammillary body. Fine. Now my dear doctors, remember that if we are able to see this diagram in one side over here, it should be exactly the same on the other side also. So let us draw the diagram, guys, as if we are seeing from above the cerebral hemisphere. We are actually seeing from above there. So let us draw the diagram in that manner. So this will be the hippocampus on one side, and then there will be a fornix going and joining with the mammillary body. Similarly, there will be hippocampus on one side, then the fornix, and going and joining with the mammillary body here. So this one here will be the hippocampus, and this one here will be the fornix, and this one here will be the mammillary body. Perfectly done. Question number 1. Fornix is going to begin from where? It is going to begin from hippocampus going to mammillary body, or mammillary body going to hippocampus. Remember, fornix is the one which is actually going to begin from the hippocampus, and it is actually going to the mammillary body. Number 1. Next, second point that you have to remember here is that the fornix on either side will be actually connected with the help of certain fibers. The fornix on the right will be connected to the fornix on the left with the help of certain fibers in the middle, and these fibers in the middle are nothing but the commissural fibers. And what is the name of these commissural fibers? Remember, it is hippocampal commissure. It is hippocampal commissure. Understanding? So hippocampal commissure is the one which is going to connect the fornix on either side. So fornix on the right and left will be connected by hippocampal commissure. Remember, hippocampal commissure is not connecting the hippocampus. It is actually connecting the fornix on either side. Done. Fine. Okay. This is also done. Now, one more important thing here that you have to remember. I hope you have learned about the white matter. And the white matter fibers are actually divided into three categories there, guys. One will be the association fibers, another one will be the commissural fiber, and another one will be the projection fiber. So white matter is divided into three categories there, guys: association fiber, commissural fiber, and the projection fiber. We all know that very well. Can anyone tell me fornix belongs to which category? That was the question asked recently in the exam. Fornix belongs to which category? Is it association fiber or commissural fiber or projection fiber, guys? Fornix belongs to which category? Is it association, commissural, or projection fiber? So in the exam, the options were given like, it is association or commissural, commissural or projection, something like that, options were given there. So what is the right thing, sir? Yes, very good. Remember one thing, yes, to your surprise, fornix belongs to all the three categories. Fornix belongs to association fiber also, as well as the commissural fiber also, as well as the projection fiber. Fornix belongs to association as well as commissure as well as the projection fiber. All the three of them. Fine. But in the exam, options were given something like this. For example, option number 1 is given as, is it association fiber and commissural fiber? Number 2, is it commissural fiber and projection fiber? Number 3, is it like association fiber and projection, something like this, options were given like this. Fine. In the class here, we are actually telling that it is belonging to all the three categories, association, commissural and projection. But in the exam, the options were given in this manner. Then what will you do? Remember, if all the three options are given in this manner, remember your fornix will be actually, yes, fornix will be actually belonging to both of these categories, mainly that is your projection fiber as well as the commissural fiber also. See, the projection fibers are the one which are actually projecting from the cortex to the subcortical region. Projection fibers means, I hope you remember in the regular classes I have taught you, projection fibers are the one which are projecting from the cortex and to the subcortical region and all. Okay, so it belongs to the projection fiber category. Commissural fiber, you are able to see that in the fornix, you are even having the commissural fibers, the fibers which are connecting the right and left, commissural fiber is also there. So if that was the question given in the exam, then the answer has to be yes. What you have to select there? You have to select both of them. That is your projection as well as commissural fiber. Normally, fornix belongs to all the three categories. It is association also, commissural also, as well as projection also. But if these kind of options are given, then go for projection as well as commissural fiber. It belongs to both the categories, guys. Is it okay? Now, this is done here, and apart from that, I hope I don't have to tell you about that. When you see, or when you look at a diagram of the brain in the coronal section, you will be able to appreciate the two lateral ventricles, and between the two lateral ventricles there is a septum known as septum pellucidum, and I hope you have seen there, septum pellucidum, the lower margin of that, the lower border of that will be having fornix attached to that one. So fornix will be attached to the lower border of the septum pellucidum. Fornix will be actually attached to the lower border of septum pellucidum there. That was actually asked in the exam. But what is my question to you people? See how many times they are asking in a different manner. Fornix is beginning from where? It is beginning from hippocampus and it is going to the mammillary body. Number 2, the fornix on either side are connected by hippocampal commissure. Number 3, fornix belongs to which category? Is it association, commissure, projection? Number 4, they have even asked you to identify that in the image based question also. Image based question, fornix, they have given a coronal section of the brain to identify the fornix. That is also done. See how many times they are asking, that is what I am trying to tell you. Now one more question which was recently asked in the exam, what is the blood supply to this fornix? Can anyone tell me which artery will be supplying the blood to the fornix, guys? I'm looking in the chat box over there. Can anyone tell me which artery will be supplying the blood to the fornix? Which artery supplies the blood to the fornix, guys? Quickly, quickly, quickly. Shall I even give you the options also? Is it ACA, MCA or PCA? Anterior cerebral, middle cerebral or posterior cerebral? Which artery will be supplying the blood to the fornix? Which artery will be supplying the blood to the fornix? Come on. Let's try to find out the answer in the next concept here, guys. Okay. Yes, look at this diagram here. And that too, yes, and that too, my dear friends, remember, hello, my dear friends, remember, and that too, remember, my dear friends, it was not given directly as a theoretical question. Actually, image was given, and that image they have just arrow marked. What is the blood supplying to the arrow marked region? Something like this. The arrow marked structure is actually fornix, and what is the blood supplying to that one? Look here at this diagram. Now, in this diagram here, this artery is the one which will be the anterior cerebral artery. This artery will be the anterior cerebral artery. I hope you remember, anterior cerebral artery is the one which is present between the two cerebral hemispheres. Between the two cerebral hemispheres. Okay, there you have the anterior cerebral artery, and that is the chief artery or the main artery on the medial surface. The chief artery on the medial surface, which is highlighted in the diagram there in the pink color. So that is the one which will be, yes, yes, that is the one which is the main or chief artery of the medial surface, and there you find the fornix. Therefore, the answer has to be the anterior cerebral artery. So fornix will be supplied by which artery, guys? That is the anterior cerebral artery. Fine. But I'll tell you one thing here. Some of the students have recalled the question that, so they did not ask for the blood supply to fornix. Some of the students have recalled that they have asked what is the blood supplying to the structure from where the fornix is arising. Are you understanding now why I am teaching you this concept here? They have asked the question that what is the artery which is supplying the blood to the structure from where the fornix is arising. So remember, fornix is arising from where? Hippocampus. And if they are asking the blood supply to hippocampus, definitely it has to be by the posterior cerebral artery. So this one here will be the posterior cerebral artery, and that is the one which will be supplying the blood to the hippocampus from where the fornix is originating. So try to have a clarity in this one, guys. Okay. Is it okay? Is it okay, guys? Yes. So hippocampus, it will be by the posterior cerebral artery, and if it is fornix, it is by anterior cerebral artery. You have to be like really careful with this one here. And lastly, I have included this diagram also, guys. In this diagram, this artery here will be the middle cerebral artery. And middle cerebral artery, it is actually the chief artery on the superolateral surface, the blue colored one which is highlighted here, that is the superolateral surface of the cerebral hemisphere. You are clearly able to see the middle cerebral artery going in that lateral sulcus or the Sylvian fissure. So that is your middle cerebral artery, and that is the chief artery on the superolateral surface. I hope you remember there are like three surfaces in the cerebral hemisphere. There are like three surfaces in the cerebral hemisphere. One will be the medial surface, and another one will be the inferior surface, another one will be the superolateral surface. Medial surface, the chief artery will be the anterior cerebral artery. Superolateral surface, the chief artery will be the middle cerebral artery, and then yes, the inferior surface, the chief artery will be the posterior cerebral artery. Posterior cerebral artery, guys. Hope you are clear about this one here. So you have to have a clarity, three surfaces supplied by three arteries over there. Done. Now the next concept, guys. Okay, I told you this concept here of the in relation with the fornix only. So I hope it is very much clear. So I hope you are writing in your books there, guys, how many different types or how many in different ways the question regarding the fornix has been asked already in the exam. So it's very much important for your exam, guys. Now once you are done with this one, let's go to the next concept, concept number 10. And in concept number 10, this is actually the transverse section of the cerebrum. In transverse section of the cerebrum, this one here will be the caudate nucleus, this is the lentiform nucleus here, and this one is the thalamus. And I am not interested in that one right now. I am interested in the white matter which is passing in between that, and that's your internal capsule. That's the internal capsule here, sir. And many questions are being asked regarding internal capsule also in your INX exam and AIMS exam, guys. First of all, the moment you look at this diagram here, let me do one thing. Let me draw the diagram separately over here. Where is, or what is the relation of your internal capsule, guys? Internal capsule, this is actually the medial side over here, and this will be the lateral side over here. So if it is the medial and the lateral side here, on the medial side, what do you have there, guys? You'll be having the caudate nucleus. Fine. And even the thalamus here. So caudate nucleus and thalamus will be towards the medial side. And then, yes, what do you have on the lateral side? On the lateral side, there will be lentiform nucleus. Yes, that is a lentiform nucleus. Now let me just remove this out from here. That is your internal capsule. Now what will be the parts of this internal capsule over here? Remember, there will be anterior limb, and then there will be a posterior limb, and then the bent in the middle is actually genu. So there is an anterior limb over here, and then there will be posterior limb, and the bent in the middle is actually the genuval part. Fine. Apart from that, you also have got the sublentiform and the retrolentiform part. Name itself is telling you it is with respect to lentiform nucleus. So the one which is behind the lentiform, that part will be actually the retrolentiform part, and the one which is actually below here, that part will be actually the sublentiform part. Guys. So kul milakar, in total, how many parts do you have in the internal capsule? Internal capsule in total will be having like 5 parts there. The anterior limb, the posterior limb, the bent in the middle is genu, and then the sublentiform and retrolentiform part. Fine. So we have actually learned from our diagram here the parts of that and relations, no doubt about that. But your AIIMS examiner is actually interested about the tracts which are going to pass through the internal capsule. Okay, AIIMS examiner is very much interested in the tracts passing through the internal capsule, and I will even tell you the reason also why. First of all, the genu part here. What is the tract which is actually going to pass through the genu part of the internal capsule? That will be the corticonuclear. So corticonuclear tract is the one which is going to pass through the genu part of the internal capsule. Okay. The name itself is telling it is from the cortex to the nuclei. Which nuclei? The cranial nerve nuclei. Perfect. Similarly, in the posterior limb, what do you have here? You'll be actually having the corticospinal tract. So what is this tract, sir? This one here will be the corticospinal tract. Perfect. Now, question number 1. Corticonuclear tract is going to pass through which part? It is going to pass through the genu part of the internal capsule. Fine. Corticospinal tract is passing from where? You can clearly appreciate in my diagram, corticospinal tract is passing from the posterior limb. Fine. But it is your AIIMS exam, it is your INSET exam. They are not asking so simply there. Is it just passing through anterior limb or posterior limb there? Yes. The 4 options given, anterior 2/3 or the posterior 2/3, anterior 1/3 or the posterior 1/3 of the posterior limb. So remember, corticospinal tract is actually going to pass through the anterior 2/3 of posterior limb. Corticospinal tract is going to pass through the anterior 2/3 of the posterior limb. You can clearly appreciate there. Corticospinal tract is going to pass through anterior 2/3 of the posterior limb. Already tested in your exam many times, sir. Chalo, one thing is done. Now I will tell you why they are asking this question so many times in your AIIMS exam and even in the INSET exam. What is the importance of this one? Try to understand here like this. Cortico, from the cortex to the nuclei. Which nuclei? Cranial nerve. And cranial nerve, most of the cranial nerve will be supplying to your head and neck structures only, except for the one, the vagus, the 10th cranial nerve, which will be moving forward and it is going all the way up to abdomen there. But most of the cranial nerves will be supplied to the head and neck part only. So therefore, corticonuclear tract, it is passing through genu. So there it is representing what, guys? The head and the neck is represented in the genu part. Then corticospinal tract, it is actually going from the cortex towards the spinal cord, and those fibers will exit out and they will be supplied to the muscles of your upper limb, and then the trunk, and then the lower limb. That is the reason why we have drawn like 3 bundles over there. The one which is more anterior will be supplied to the upper limb, then in the middle the trunk, and then the fibers which are more posterior will be actually supplied to the lower limb. So in short, what I am trying to actually tell you here is that the entire body, your entire body is actually represented here, guys, in the internal capsule. So in the internal capsule, your entire body is actually represented. That is the reason why examiner want to test you whether you know about that or not. So tracts passing through the internal capsule, this is extremely important. So with the help of this diagram, we have covered the relations of internal capsule, the parts of internal capsule, and even the tracts which are passing from the genu part as well as the posterior limb, anterior two-thirds of the posterior limb, and what is the importance of this one, guys. Okay. Next one, moving on to the next concept here now. The concept number 11 is about the ventral aspect of brainstem. The moment you look at this diagram here, no doubt here, this one will be the midbrain. This big bridge-like structure here will be the pons. Pons meaning itself is bridge, and this one here will be the medulla oblongata, followed by the spinal cord. So basically, this is brainstem, and that to which aspect, that is important. This is the ventral aspect of brainstem, sir. That is the ventral aspect of brainstem. Perfect. The midbrain, pons, and medulla oblongata. Now, what is the main important thing that everyone has to remember here, guys? The origin of the cranial nerves. Everyone knows that the cranial nerves from 3 to 12, except the first and second one. The first one olfactory and the second one optic, except leaving the first and second one there. Remaining 3 to 12, everything will be originating. All the cranial nerves will be originating from the brainstem only. Fine. Now, out of this, remember the cranial nerve number 3 having the ventral origin here, and the cranial nerve number 4 coming from the dorsal aspect. Both of them will be originating from the midbrain. We know that. Third one will have ventral origin, and the only cranial nerve which is having dorsal origin, the fourth one will be having dorsal origin and taking a turn and coming in the front. Then you are able to see the fifth cranial nerve, that is your trigeminal nerve. Trigeminal nerve will be originating or coming out from the pons, and then sixth and the seventh and the eighth cranial nerve will be coming out, they will be exiting out from the pontomedullary junction. And then finally, you are able to appreciate here the 9th year and the 10th year and 11th, 9th, 10th and 11th, and even the 12th month. All of them will be coming out from the medulla oblongata. Now, if you want to learn in more depth, my dear students, remember this elevation here is actually referred to as pyramid. Okay. And more lateral to pyramid here, this elevation is actually referred to as olive. Why? Why? Because olive, it is the one beneath that, below that, you will be able to find a nucleus that is nothing but the olivary nucleus. And of course, it will be inferior olivary nucleus. Why? Because superior olivary nucleus will be in the pons only. So, inferior olivary nucleus is the reason why it is elevated there, guys. Okay. So, that elevation olive is due to actually the inferior olivary nucleus, and that elevation is pyramid. So, if you want to learn in more depth, 9, 10 and 11, the cranial nerve number 9 and then 10 and 11, these three are going to exit out lateral to olive, whereas the 12th one is between the pyramid and olive. The 12th nerve is between the pyramid and olive. Fine. This is the basic information that you have to always know as a medical student, okay, in your first year MBBS itself. Now welcome to the AIMS exam or INSET exam. What is the question that they have asked here? Question number 1. Just now I told you about the corticospinal tract. Corticospinal tract is nothing but the pyramidal tract. Corticospinal tract. The another name of the corticospinal tract, remember, it is also known as the pyramidal tract. You know very well, it's a very famous thing, guys. The pyramidal tract is going to cross, and that crossing is actually referred to as the pyramidal decussation. The crossing will be actually known as the pyramidal decussation. Where it will occur exactly? Where will the pyramidal decussation occur exactly? Now remember, the pyramidal tract crossing, that is pyramidal decussation, will occur in the lower medulla. So in the lower medulla, what is going to happen, sir? The fibers are actually going to cross. Almost 90%, 85 to 90% of the fibers are actually going to cross in the lower medulla. That's important, fine. Now, what is the question given in the AIMS exam? The question in the AIMS exam was, this arrow marked region is actually having a lesion. There is a lesion in the arrow marked region. Now, look at the question which was asked in the AIMS exam. This arrow marked region is actually having a lesion there, guys. Then what will be the effect? Now, you try to understand here something like this. For example, if you have your pyramidal tract coming here, and then the pyramidal tract fibers are going to cross in the lower medulla. Similarly, from the other side also, the pyramidal tract fibers are actually going to cross in the lower medulla. That means, if there is an injury in the arrow marked region there, that means the crossing has not yet occurred. Crossing abhi nahi hua hai. All that 100% of fibers are there in the pyramid. So therefore, my dear friends, if there is an injury in this region, if there is a lesion in this region, definitely what is going to happen? The effect will be actually seen in the contralateral side. Why? Because after that it is actually going to cross. So therefore, it will lead to hemiplegia. I am really happy with your answer there, but the important thing is contralateral. It is leading to contralateral hemiplegia. So if there is an injury in that region, remember it is due to what, sir? It will be leading to what? It will lead to contralateral hemiplegia. So how can you come to that conclusion of contralateral hemiplegia? First of all, you should know that it is pyramid, and that pyramid elevation is actually formed due to a tract known as pyramidal tract. So that pyramidal tract is the one which is going to form that elevation, that is due to, yes, of course, Karthik, okay. So that pyramid elevation which is formed there, it is due to a tract, that nothing but the pyramidal tract. So agar wo injure hoga, if that is injured there, then what is going to happen there, guys? Yes, it will lead to contralateral hemiplegia, because crossing will take place in the lower medulla. That was the question given in the recent exams, 2019, 2020. AIMS examiner is very much interested about the pyramidal tract. Done. That is one thing. Now one more thing I'll tell you here. I hope you all have learned about the circle of Willis. Circle of Willis, everyone knows about the circle of Willis, hai na? Now circle of Willis, first of all there will be a vertebral artery here, and there will be another vertebral artery from the other side, and both of them will combine together to form your basilar artery, and basilar artery will be lying right on the pons. So vertebral artery here and the vertebral artery on the other side, these two will combine together to form basilar artery. Basilar artery is lying exactly on the pons. Now what is happening here is that basilar artery will go and end. Basilar artery will actually go and end there by dividing into posterior cerebral artery. That's your PCA. So imagine this one here to be your PCA, posterior cerebral artery. That's your PCA, posterior cerebral artery. Fine. Basilar artery is actually terminating, it is ending by dividing into the posterior cerebral artery. Fine. Now not only that, remember, my dear friends, the basilar artery will also give a branch here to the cerebellum from above. Okay, I hope you are able to appreciate the cerebellum over here. So it is also giving a branch to the cerebellum from above. So therefore, what is the name of this artery here? This one will be the superior cerebellar artery. Remember, I am telling cerebellar artery, not cerebral, cerebellar artery. So let me just enlarge this picture here. So this one here will be the posterior cerebral artery, and this one here is the superior cerebellar artery. Both of them are the branches of basilar artery only. But my point is not that one here. My point is that what I am trying to teach you here is that, yes, between these two arteries, are you able to appreciate the third nerve over here? Yes. And the fourth nerve over here? Yes. So remember, the third and the fourth cranial nerve, oculomotor nerve and trochlear nerve, is between which two arteries? Question asked in the exam. It is between which two arteries there? Remember, the third and the fourth nerve, these two nerves are between the posterior cerebral artery and the superior cerebellar artery. I repeat again, posterior cerebral artery and the superior cerebellar artery. So you will be always learning the circle of Willis separately, and then the brain stem separately. So let's overlap them today, and let's see in a different manner here, guys. So if you appreciate here, you will be easily able to understand, and no need to mug up, guys. And agar aap mug up karoge, if you even mug up also, hardly you'll be able to remember for a couple of days there. Don't do that. The best way, learn with the help of this diagram here, sir. Okay. So basilar artery will be dividing into the posterior cerebral artery, and then there will be superior cerebellar. Between those two, you'll be able to see the third nerve and the fourth nerve. Third and the fourth nerve between them, guys. Yes, of course, Rochelle. चलिए आगे बढ़ते हैं sir. Let us move on to the next concept. So there are certain questions which are being asked from the ventral aspect of the brain stem also. I request all of you to please remember that. Okay. Next one, guys. Prakash, volume is actually perfect. I think others are also perfect there, comfortable there, guys. So we are already done with about these arteries here. So we don't have to repeat this again, guys. Already we are done with this concept of arteries. And why I included this in our discussion over here? Why? Because yes, there was a question regarding the blood supply to fornix. Okay. Next one, concept number 13. Welcome here. Oh, I have recently done this concept in the in YouTube session already, guys. Nowadays what is happening is, previously they used to ask about the cranial foramen. So foramen used to be given, and like which foramen, what is the structure passing. But nowadays what they are doing is directly they are giving this image here, and in this image, yes, not about the foramens, it's about the cranial nerves now. Which cranial nerves? So you should be in a position to even identify the cranial nerve. Let us do it very quickly here. The cranial nerve which is actually going to pass through the cribriform plate over here, it is nothing but the olfactory nerve. So cranial nerve number 1, olfactory nerve. And then this one that you are able to appreciate here, that is nothing but the cranial nerve number 2, optic nerve. And that process there is the anterior clinoid process, and that is nothing but the optic nerve there, guys. Okay. Then actually those two are very much easier, no problem with that one. The actual confusion comes here now. Now in this diagram here, you are able to appreciate there are like many nerves over there, guys. Out of this now, how to identify? Remember, this is the third cranial nerve, that is your oculomotor nerve. That is the third cranial nerve. And out of all this, remember this one here will be the fourth nerve, that is your trochlear nerve. So that is oculomotor nerve and trochlear nerve, guys. Now you might be thinking, sir, how are you able to identify these two here? I'll tell you one simple logic here. Listen with all your ears open. I'll tell you one simple logic here, how to identify. Just now, few minutes back, I told you third and fourth nerve are going to begin from midbrain only. Third nerve and fourth nerve, both of them are going to begin from the midbrain only. Okay, but third nerve has got the ventral origin. It is originating ventrally only. But fourth nerve is the one which is having dorsal origin, taking a turn and then coming from the side. So the one which is like more farther away, that is actually the fourth nerve. That is the simple logic to identify. So the third nerve is right here, and then the fourth nerve, because it is going to take a turn and come, that is the reason why it is the one which is a little bit away from there. Easy to identify. In between this third nerve and the fourth one, the one which you are able to appreciate there, yes, in between the third and the fourth one, the one which you are able to appreciate there is your sixth nerve. And this sixth nerve, I told you just now, abducens nerve, it is the one which is coming from the nucleus of that is present in the pons, and it is the one which is coming up or exiting out from the pontomedullary junction. You remember that 6th, 7th and 8th pontomedullary junction. So from there it is going to jump up, it is going to move up through that slope, and that slope wala part is actually known as the clivus. Understanding here? So this slope here is actually the clivus, and above that clivus, whatever nerve which is going to, move up is your sixth nerve. That is the logic to identify if it is given in the exam. Okay. So if it is given in the exam, remember the one which is actually ascending up through that slope, clivus there, that is the sixth nerve. Third nerve is having ventral origin, and the fourth nerve is taking a turn and coming from behind. Wow. So the most confusing wala part is made very crystal clear here, guys. And after that, every student can tell this is the largest cranial nerve, not longest, largest in size wise. That is your fifth cranial nerve. Trigeminal nerve, trigeminal ganglion there, and that trigeminal nerve will be dividing into 5-1 ophthalmic, 5-2 maxillary, and this one will be the 5-3, that is your mandibular. 5-1 ophthalmic, the branches of that will be going through the superorbital fissure. 5-2 will be maxillary, maxillary is going through the foramen rotundum, and 5-3 will be the mandibular. Mandibular nerve is going through the very famous one, that is your foramen ovale, foramen ovale. After that, here this is the internal acoustic meatus, internal acoustic meatus, and from here you will be actually having the cranial nerve number 7 and 8 passing from there, facial and vestibular cochlea. Then this big foramen that you are able to appreciate here, that is your jugular foramen, cranial nerve number 9, 10 and 11. You can clearly see the 11th accessory nerve coming from below, 9, 10, 11. And then this is your hypoglossal canal here. I'll just write down in short as hypoglossal canal. That is the 12th nerve passing from there. So you are able to appreciate that nerves there, guys. Perfect. I'll tell you one more thing here, guys. What happened, why I have included this one here. I'll tell you the reason behind this one, and why should you prepare before going to the INSET exam. Why did I include this topic here? Why? Because not only identifying this cranial nerve, what they are doing is, one of the hot favorite topic of AIMS examiner and even INSET also, is that extraocular muscles and their nerve supply. They will never ever get tired in asking the question regarding this one, guys, extraocular muscle and the nerve supply. So there was this diagram given, but in this diagram they did not ask you to identify the nerve here. No. They have actually marked a few nerves here. For example, this was marked like something like A here, and this was marked like B here, something like this. This was actually the C here, and this one is D here. Out of the following, all of them will supply to extraocular muscle except one nerve. All of them will be supplying to extraocular muscle except. Now every student knows extraocular muscles will be supplied by which nerve? What is the nerve supply? SO4, LR6, rest all by 3. SO4, LR6, rest all by 3. So fourth nerve, third nerve and the sixth nerve will be supplying. And I told you in our today's class crystal clearly how to identify the nerve. And once you have identified the nerve, khalas, question is gone. So examiner is not worried about the extraocular muscle nerve supply. He is all worried about the identifying these nerves over here and correlating the concept there, guys. Is it okay? Fine here. Yes, optic nerve will not supply. Very good, Dr. Ghosh. Optic nerve will not supply to the extraocular muscle. Very nice. So these type of questions are given there, guys. Then again, not only that, one of the diagrams, something like this was given in the exam, and yes, you have to actually identify first of all the extraocular muscle. Then I will tell you. First, let us identify the extraocular muscle. Then I will actually tell you about the question. Now, extraocular muscle, we all know. First of all, there will be like 4 recti muscles. This one here will be the superior rectus, and above the superior rectus, remember this one here will be the LPS, levator palpebrae superioris. So when we discussed about the cranial nerve number 3, oculomotor nerve, I have drawn the diagram in a schematic manner, and we have seen that superior rectus, and then there will be the levator palpebrae superioris. Fine. Then the next one here, this one here will be the lateral rectus muscle there, guys. Fine. And this one here, no doubt about that, this one will be the inferior rectus here, and this one here will be the medial rectus. Fine. There will be 4 recti. 4 recti and 1 LPS is done. Then what about the oblique here? Yes, this muscle that you are able to appreciate here, this one will be the superior oblique, and this one here will be actually the inferior oblique muscle, sir. Superior oblique and inferior oblique muscle, I hope you are able to appreciate that in the diagram. Now, once you are clear with this one here, the question was, once you have identified the muscle here, the question was very simple. What is the nerve supplying to the arrow marked muscle? And this was the muscle which was arrow marked here. This one. Which one? Superior oblique. Everyone knows superior oblique will be supplied by the 4th cranial nerve, trochlear. Even a first year MBBS student can easily answer that one. Superior oblique is supplied by 4th cranial nerve, that is your trochlear nerve. But the challenge here is identifying those extraocular muscles. So I hope you are easily able to identify the extraocular muscles right now. Moving on to the next concept, guys. Wow, another very important concept, that is about the deep cervical fascia, and it is hot favorite of the AIMS examiner here, sir. So deep cervical fascia, the fascia in the deep cervical fascia, the fascia in the neck here. Fine. This deep cervical fascia here, it is further actually now modified. There are certain modifications of that one. The one which we are able to appreciate here, this red colored one, which is surrounding the entire neck, guys. There is like around the entire neck, like a neck band over there. It is around the entire neck, and that is actually splitting and enclosing 2 muscles. One will be the sternocleidomastoid muscle over here, you can appreciate here in the diagram, and then the trapezius muscle over here, sir. So it is splitting and enclosing these 2 muscles, and this layer, this red colored one here, this is referred to as your investing layer. Investing layer. So it is going to split and enclose these 2 muscles. Not only these 2 muscles, it's like having a rule of 2. It will be enclosing 2 muscles, and then there will be 2 glands, and then 2 spaces, everything like double guys. 2 muscles, 2 ligaments also there and all. Investing layer. And this blue colored one that you are able to appreciate here, which is enclosing the thyroid gland over here, this one here will be the pretracheal fascia. Pretracheal fascia, guys. And this yellow colored one over here, which is surrounding the vertebrae, cervical vertebrae, and the muscle surrounding that one, that is nothing but the prevertebral fascia. That is prevertebral fascia. Fine. So there will be prevertebral fascia, and then there will be pretracheal fascia and investing layer, and finally the most important one here, this one here will be the carotid sheath. So all these 4 things whichever I have written here will be the modifications of your deep cervical fascia only. So deep cervical fascia has got like modifications here. One is the investing layer, the pretracheal, the prevertebral, and the carotid sheath here. And apart from that, we'll also go into some more modifications, guys. First, let us learn about the carotid sheath over here. What is the content? You can clearly appreciate there will be a common carotid artery present inside that, and even the internal carotid artery, not the external. Why? Because external carotid artery will pierce the carotid sheath and it will be actually coming out, guys. Okay. So what do you have inside that one? It is only common carotid artery and as well as internal carotid artery. And then there is a vein present inside that. There is your internal jugular vein, and the only nerve present there is vagus nerve. And yes, that was asked in the exam. So between the artery and the vein, you can see one nerve which is sandwiched between them, and that is your 10th cranial nerve, that is vagus nerve. Vagus nerve was actually asked in the exam, guys. That is the vagus nerve. So the only one nerve present inside the carotid sheath will be the vagus nerve, and vagus nerve was already asked in your AIIMS exam. Done. Now, what are the relations of this one, guys? What are the relations of the carotid sheath? Carotid sheath, now anteriorly what do you have there? Anteriorly there will be ansa cervicalis, and posteriorly you will be having the sympathetic trunk. So this one that you are able to appreciate here, this one is actually the sympathetic trunk. Sympathetic trunk here, sir. Fine. So inside there will be vagus nerve, and outside and posteriorly you will be actually having the sympathetic trunk. Sir. Posteriorly there will be sympathetic trunk. Fine. Now, till here it is well and good. Every student will be learning this one. But what is the confusion created there? The confusion created in the exam was, what is the nerve present inside the carotid sheath, sir? The nerve present inside the carotid sheath is actually the vagus one, the 10th cranial nerve. But remember, not only the 10th one, even the 9th nerve as well as the 11th nerve will also be present there. Sir, how come the 9th and 11th nerve is also present? It is the content of carotid sheath. I will tell you how. This diagram of carotid sheath actually we are saying in the transverse section here. We are actually saying in the transverse section. Fine. But when you see like the entire carotid sheath, it is beginning from where? Remember, just now I taught you, when you will study about the base of the skull, in the skull, from the base of the skull, you will actually have the jugular foramen, and from there jugular foramen just adjacent to that you will be actually having the carotid canal also, and from there only what is going to happen, the carotid sheath is going to begin. I repeat again, the jugular foramen, the carotid canal, wherever you are having that one, from there only, from the base of the skull, from there only what is going to happen, carotid sheath is actually going to begin there. And the moment I tell you jugular foramen, which nerves are going to pass through jugular foramen? 9, 10, 11. Which nerves are going to pass? 9, 10, 11. So what is going to happen? For example, you just for the sake of imagination, schematic diagram, jugular foramen. Just imagine jugular foramen. And from there, what is going to happen? Our carotid sheath is going to descend down. Carotid sheath from there. Now, the nerve which is going to pass through jugular foramen will be the 9, 10, 11. But what is having out of these three is only the 10th nerve is the one which is going throughout the carotid sheath, whereas the 9th nerve will enter the carotid sheath and just go out there, exit out, and the 11th nerve will also exit out. So, are they a content of carotid sheath? Yes, but not throughout the carotid sheath, only in the upper part of that one. Only in the upper part of the carotid sheath they are the content, but not throughout the carotid sheath. So, that was actually given in the exam, and it has created a lot of confusion among the students, but remember it is true. So, 9th as well as 10th as well as 11th, all these three nerves will also be the content of carotid sheath, but not throughout the length or throughout the entire carotid sheath. Remember, it is only in the upper part. So, from today onwards include the common carotid artery, internal carotid artery, internal jugular vein, vagus nerve. Along with the vagus nerve, remember even the 9th as well as the 11th nerve also. Glossopharyngeal as well as the accessory nerve was also content, guys. Perfect. Next one. Now, let us go a little bit in more depth right now, guys. This will be the scalenus anterior muscle over here. This one. So, this is the cervical vertebrae, guys, and cervical vertebrae you are able to see the transverse process. Attached to the transverse process there is a scalenus anterior muscle, and then you will be actually having the scalenus medius muscle, and then there will be scalenus posterior muscle. So, there is scalenus anterior, scalenus medius and scalenus posterior muscle, three of them. But now what I am trying to teach you here, right in front of the scalenus anterior, I am able to see there is a nerve here. Which nerve is this one, which is present right in front of the scalenus anterior muscle, and that will be the phrenic nerve. Phrenic nerve. Now, what is the origin of the phrenic nerve? The phrenic nerve will be originating from C3, C4 and C5 cervical. Now, after beginning from here, remember the phrenic nerve is going to pass in front of the scalenus anterior muscle. In front of the scalenus anterior muscle. That is a trick to identify that one. Now between the scalenus anterior and scalenus medius, you are able to see one more nerve over here, and that one will be your brachial plexus. And this we have been learning from our first year MBBS. Brachial plexus is the one which is going to pass between scalenus anterior and scalenus medius. So scalenus anterior and the medius, between them you will be actually having the brachial plexus passing from there, guys. That is the way how you identify the brachial plexus in the middle and then the phrenic nerve in the front of that one. And if it is given inside the carotid sheath, definitely it will be vagus nerve only, and posteriorly behind that will be sympathetic. If you are still like, sir, we want to learn something more, yes, this one here will be the trachea, and behind the trachea this is esophagus here, and in the tracheo-esophageal groove I am able to see one more nerve. And what is the name of this nerve here? This is the recurrent laryngeal nerve. Recurrent laryngeal nerve is the one which is going to pass through the tracheo-esophageal groove. So that is the reason why I think now you will 110% agree with me right now. This section very much important, very much important here, sir. Perfect. So you have to know about the deep cervical fascia, all the fascia there, the modifications, and then something important regarding the carotid sheath, and even the nerves. You should be in a position to identify all these nerves here, guys. Good one, sir. Moving on to the next concept right now. Now in the next concept, I want you to learn about the relations of the scalenus anterior muscle. Learn the relations of the scalenus anterior muscle, guys. So what is this muscle over here? This muscle is actually the scalenus anterior muscle. This muscle here is scalenus anterior muscle, and they are asking the relations of this one a lot of times, guys. Let's see what are all the relations of scalenus anterior muscle. Now first of all, anteriorly what do you have here, sir? Number one is, yes, are you able to see the vein and the artery here? This is the subclavian vein and the subclavian artery, and yes, subclavian vein, it is the one which is going anteriorly, whereas the subclavian artery is the one which is going behind. So this is the subclavian artery here. Subclavian artery is going behind the scalenus anterior muscle. Now my dear doctors, what I want you to learn here is that even though this subclavian artery is going behind, I hope you remember subclavian artery is divided into three parts. The first part before the muscle, second part will be actually behind the muscle, and third part is like after the muscle. Fine. I am speaking about the artery. Subclavian artery is divided into three parts. The first part, second part, and third part. First part will be before the muscle, second part will be behind the muscle, and third part is after the muscle. Fine. Now first part of the subclavian artery we have learned a lot of time. It will give three branches, WIT branches, V-I-T, WIT branches. So V for vertebral, I for internal thoracic, and T for thoracocervical. So my dear friends, remember the first part of the subclavian artery will give like three branches. V for vertebral artery will be going up, not seen in this diagram, you leave about that one. I for internal thoracic artery will be actually going down into the thorax, that is also not seen in this diagram, you leave about that one. The last one that you are able to see here is only T. There is a T here, and the T stands for thyrocervical trunk. And that thyrocervical trunk is in turn divided into how many branches? Three branches, that is SIT branches. I hope you remember this mnemonic I told you many times, guys. The first part of the subclavian artery will give VIT, WIT branches, and T will in turn give you the SIT branches. Let's see what are those SIT branches. S stands for this one here. S stands for suprascapular artery. And then this I stands for inferior thyroid artery here. This is going to the thyroid gland there, inferior thyroid artery. And then finally this one here, guys, this one will be the transverse cervical artery. Transverse cervical. Name is very much meaningful there. Transversely going in the neck region, transverse cervical artery. So this one is suprascapular artery, and this one is transverse cervical artery, and this one here will be the inferior thyroid artery. So remember, all the three branches are anterior relation of scalenus anterior muscle. So I repeat again, even though the subclavian artery is going from behind, remember the three branches given, that is your SIT branches, are going from the front of the scalenus anterior muscle. Perfectly done. Now Now apart from this, I want you to learn there are 4 nerves which are visible in this diagram, and you should be able to identify the 4 nerves, and I'll tell you the easiest way to identify. First of all, this is internal jugular vein here, okay ji, and this one will be the common carotid artery, okay ji. And if that is internal jugular vein, common carotid artery, what is the nerve which is sandwiched between them? Between them, this nerve which is sandwiched, there is the vagus nerve, the 10th nerve. Wow, easy to identify. And how we are able to identify? Just now we have learned all this is actually present inside a sheath, and that's your carotid sheath here. Oh my god. So that is a carotid sheath, and inside that you are able to see the internal jugular vein and the common carotid artery. Between the vein and the artery, you are able to appreciate there the vagus nerve there is. Done. Now just now I told you the posterior relation of the carotid sheath. What do you have behind the carotid sheath? Behind the carotid sheath will be the sympathetic trunk. So this one definitely has to be the sympathetic trunk only. Kya baat? So easily able to identify. Okay. So inside the carotid sheath there will be vagus nerve, and behind the carotid sheath there will be sympathetic trunk there, guys. Lovely. If you just follow this vagus nerve, the vagus nerve is moving down here, and then it is going to give a branch, and that branch is going to take a turn here, and yes, it is going to come back here. In between the trachea and the esophagus there, that is tracheoesophageal groove. So definitely this nerve here has to be the recurrent laryngeal nerve. Of course, superior laryngeal nerve and recurrent laryngeal nerve, both of them are the branches of vagus only. Superior laryngeal nerve and recurrent laryngeal nerve, both of them are the branches of vagus only. So that is your recurrent laryngeal nerve, easy to identify. Or otherwise, I'll do one thing here. Let me remove this line so that you will be easily able to see there. Wow. So you're able to easily appreciate there, guys. 3 things are done. We are perfect with the vagus nerve. You're able to identify from today onwards sympathetic trunk, and then you're even able to identify the recurrent laryngeal nerve. Done. Now the last one which is remaining, and which was actually asked in your exam, is yes, what about this nerve over here? That nerve is in front of the scalenus anterior muscle. Recall. So this is actually the scalenus anterior muscle, and there is a nerve in front of the scalenus anterior muscle, and that one will be the phrenic nerve. You people only told me here. So definitely, if it is in front of the scalenus anterior, it has to be the phrenic nerve. Phrenic nerve. So I want all of you to, my dear friends, all of you to remember that if this diagram is given, you should be able to easily identify these 4 nerves over here. And if you are still getting confused here, I'll tell you one more trick here, guys. One more trick I'll tell you. The vagus nerve is the one which is going to pass in front of all those 3 branches. Vagus nerve is going to pass in front of that 3 sit branches, SIT, sit branches, whereas phrenic nerve is the one which is going to pass behind those 3 branches. That is also one more hint to identify. That is also like one more hint to identify these nerves, guys. So don't get confused between those 2 nerves if you see in the exam. Tomorrow they might even give you a cadaveric image also. Oh my god, look at this beautiful cadaveric image over here. Now in this cadaveric image, yes, I hope you are able to appreciate here, this one will be actually the scalenus anterior muscle. This is the scalenus anterior muscle over here. Now in this diagram, I am able to see one nerve which is passing right in the front over here, this one, and I am able to see one more nerve here, this one, which is going to pass behind those arteries. So that is the trick to identify, yes sir, this one which is going to pass behind those arteries will be the phrenic nerve, and the one which is going to pass in front will be the vagus, the 10th nerve. I hope this trick will actually help you in identifying these nerves easily. Are you all comfortable with this one here? And without any doubt, the one which is going here, this artery here, let me just use a red color here. Yes, this artery here will be the suprascapular artery, and this is the transverse cervical artery, and the one which is going towards the thyroid gland here, this is the inferior thyroid artery. Those 3 are the branches of the thyrocervical trunk, which is in turn is a branch from the first part of the subclavian artery, guys. So that's a beautiful diagram of the scalenus anterior muscle, and easily you will be easily able to identify all these relations there, guys. Perfect. Please raise the volume. Mehta ji, volume perfect hai. Everyone is perfectly able to listen to that one. Next one, sir. Next one. The next concept, the concept number 16 right now, so let's go ahead. The concept number 16 that we are going to discuss right now is about the larynx, another very important concept, larynx and the cartilages of larynx and also. Now we all know larynx has got like how many cartilages? So totally 9 cartilages, and there will be like 3 paired and 3 unpaired cartilages. 3 paired cartilages, 6 of them, and 3 unpaired, there will be only 3 of them. So totally 9 cartilages. Now out of that 9 cartilages, every student will be able to identify this one here is the epiglottis, guys. That big leaf like one, unpaired epiglottis. And this cartilage here will be actually the thyroid cartilage, guys. This is the thyroid cartilage, the large one. Okay. And below here the ring like structure or ring like cartilage here will be the cricoid cartilage. This is the cricoid cartilage here. And the one above the cricoid cartilage, this one here will be the arytenoid cartilage. This is the arytenoid cartilage. So there will be cricoid below, and then above that you will be able to see the arytenoid cartilage. Perfect. Then if you are able to appreciate in this diagram here, if you are able to appreciate in this diagram here, there will be like cuneiform and corniculate. Don't worry about that, that will not be asked there. So this is the cuneiform and the corniculate here. So epiglottis here, the thyroid here, arytenoid and the cricoid, and of course this bone above here will be the hyoid bone. This is your hyoid bone over here. But the problem is, in recent exam, in recent INSET exam, the question was not about this textbook wala image or atlas image. The question was given from the cadaveric image. Now how to identify the cadaveric image? Easy to identify, the easiest one. This big leaf like cartilage here, this one has to be what, guys? That has to be your epiglottis. So this one here will be actually the epiglottis one. Perfect. And then right in the front you can clearly see this one here will be actually the thyroid. That is the thyroid cartilage, guys. Perfect. Epiglottis is actually the one which is actually attached to the inner aspect of the thyroid only. So this epiglottis, the leaf like, it is the one which will be attached to the thyroid on the inner thyroid cartilage. Then below here, because it is actually a section here, below here you are able to appreciate the cricoid cartilage, and that is actually the lamina of the cricoid cartilage, and it is going to take a turn, and you can see on the other side the arch of that one. So this one here will be the lamina of the cricoid cartilage, and there will be the arch there, guys. So basically this one here will be the cricoid cartilage below. And what is situated above the cricoid cartilage, guys? I'm just writing here, this is cricoid cartilage, and this one here is the thyroid. What is sitting just above the cricoid cartilage here? This one will be your arytenoid cartilage here, guys. This is the arytenoid cartilage over here above. This is arytenoid here. So epiglottis, the cricoid cartilage, the thyroid cartilage, and arytenoid there. And finally, what is this structure, guys, above the epiglottis there? And that is nothing but the bone. It is not the cartilage. That is the bone. That's your hyoid bone there, guys. That is the hyoid bone present over here. So it's in a section there, in a cut section. That is the reason why you are able to appreciate the diagram in this manner. Now, why did I include this question over here, guys? Why? Because recently in the exam it was given, all of the following are going to form the skeletal framework of larynx except one. So all of the following are going to form the skeletal framework of larynx only. All of them are going to form the skeleton of larynx. Skeleton of larynx is made up of cartilages only, except the hyoid bone. Hyoid bone doesn't have any role to play in the formation like in the larynx, guys. Okay. So except the hyoid bone, all of them are going to be a part of skeletal framework of the larynx, not the hyoid bone. But the important thing is, everyone knows theoretically, the important thing is to identify that too in the cadaveric image. That is important. Even textbook wala image is also very much easier only. You can clearly see there, the textbook image is very easier, but the cadaveric image, okay, a little bit tricky to identify. So if that is the reason why I have kept it like comparison, so that you will be easily able to identify that one here. Next one. Now after this one, let us go to the next concept, concept number 17. And the concept number 17, after completing about the neuro, head and neck and all those things, guys, now I want to slowly move towards the histology wala part. And in histology, the students who are preparing for INSET exam, I request all of you to please learn very perfectly about the epithelium. 2020 INSET, they have asked about the epithelium. Okay, the epithelium which is actually having the cilia in that one. So most of the time they are asking about the epithelium only, and before that in the AIMS exam they have asked about the transitional epithelium, like urothelium is present there, guys. Okay, so I request all of you, the students who are preparing for INSET exam, to please learn epithelium, and that too about the examples, like where exactly do you have all those epithelia present. So my dear doctors, do one thing. The best way to learn about the epithelium is divide that into three parts there. The epithelium present in your entire gut, GIT, then the epithelium present in the respiratory tract, and the epithelium present in the excretory tract, like your kidneys and urethra and urinary bladder. So I always try make the students to learn in this manner only. There is another method totally opposite, vice versa. The type of epithelium, for example, simple squamous present at which part? There the students are actually getting confused. Why? Because simple squamous epithelium present in alveoli, it is also present at the Bowman's capsule. So in that manner now it is getting very much difficult to remember different examples present there. The best way, follow the sequence, remember three systems, you are done. That is the best trick to learn about the examples of epithelia, guys. Is it okay? So welcome to the gut here. First of all, starting with the esophagus. Esophagus definitely, and there is a simple logic here to remember, guys. In esophagus, should it be like a simple epithelium or stratified epithelium? Simple, single layer, or stratified? It has to be stratified only. Wherever there is a wear and tear, okay, yes, there it has to be actually stratified only. So that is the reason why in esophagus you actually have stratified squamous epithelium, multiple layers of squamous epithelium. Of course, it will be non-keratinized. Keratinized will be actually present on the skin and all those dry surfaces, but in the esophagus it will be non-keratinized. In the stomach, it is not about the wear and tear, guys. In the stomach and intestines and all those things, there will be actually having the columnar epithelium. So stomach, you actually have the simple columnar epithelium, which is actually, of course, covered by mucus. Mucus cells will be present over there. And then again the same thing, guys, whether it is small intestine or large intestine, or we can see the colorectal zone or ATZ, or even the squamous zone in the anal canal. Yes, there all the places you are actually you are able to see the columnar epithelium everywhere. But in the squamous zone from A to Z, what is going to happen? From the transitional zone, from the anal transitional zone, slowly when you are moving towards the skin over that anal region there, squamous zone, there again you will be actually having the squamous epithelium, and of course stratified. Why? Because there also it will be like wear and tear only. Now respiratory epithelium, the important thing that you have to remember, like every system has got a one particular epithelium, guys. For example, gut, it will be always having the columnar epithelium. Whereas in respiratory epithelium, you will be having what, guys? You will be having the pseudo-stratified ciliate epithelium. So whether it is the nasal mucosa, the paranasal air sinus, larynx, trachea, bronchus, proximal bronchiole, till all your bronchiole, right from the nasal mucosa up to the bronchiole, I am telling you, trachea and even bronchus and bronchiole, you will be having the pseudo-stratified ciliated columnar epithelium. Pseudo-stratified ciliated columnar epithelium. Okay. From there, it is going to change. Terminal bronchiole is the one which will be having the ciliated cuboidal epithelium. Respiratory bronchiole will be having cuboidal only, but non-ciliated, important. And alveoli, of course, where exchange of gases will take place, will be actually having squamous epithelium, simple squamous epithelium. Alveoli will be lined by that flattened epithelial cells, simple squamous epithelial cells. So most of the places in the respiratory tract, it will be actually pseudo-stratified ciliated, but remember till where? Till the proximal bronchiole. Moving on to the urinary tract epithelium, or it is nothing but the urothelium. Urinary tract epithelium or urothelium, recently asked in the AIMS exam, you have to remember this one. So Bowman's capsule, PCT, loop of Henle and DCT. Remember, it is like alternative here. If it is Bowman's capsule, then PCT, the loop of Henle, and then DCT and collecting duct. In the Bowman's capsule, it will be like simple squamous epithelium, simple squamous. PCT again it will be like cuboidal. Loop of Henle again it will be squamous. DCT and collecting duct it will be again cuboidal. So it's like alternating, guys. Okay. So squamous, cuboidal, squamous, cuboidal. Try to remember like that: squamous, cuboidal, squamous, cuboidal. So let's see. Bowman's capsule it will be actually squamous, and then PCT it will be again cuboidal. Whereas loop of Henle, this is like descending limb, loop of Henle and all. There again you will be actually having the squamous only, but again when it is coming to thick ascending limb, DCT and the collecting duct, everywhere it is again cuboidal only. So Bowman's capsule will be squamous, PCT is cuboidal, loop of Henle is again squamous, then DCT and collecting duct will be cuboidal, guys. Okay. Then from there on, the characteristic epithelium present in the excretory system will be transitional epithelium. So I hope you are observing there. When it is gut, when it is GIT, it is actually columnar epithelium. When it is respiratory tract, it is actually pseudo-stratified ciliate epithelium, the main important one. And in the urinary tract, it is mainly transitional epithelium. Transitional epithelium, sir. So minor calyx, major calyx, renal pelvis, ureter, bladder, the entire thing from the kidney, the ureter, the bladder, and up to the prostatic urethra, it will be transitional epithelium. Urethra in the males is divided into three categories: prostatic, membranous, and penile urethra or spongy urethra. So prostatic urethra till there it is transitional. Then membranous urethra will be having pseudo-stratified columnar epithelium. Even spongy urethra will also have pseudo-stratified columnar epithelium. But terminal urethra, as I told you, the terminal urethra, the last part of the urethra, which is going to open into that glans penis, and from there it is going to come into the surface. So therefore, what is going to happen? Again the same thing: wear and tear, squamous, and that too multiple layers, stratified, squamous epithelium. So if you apply a little bit of common sense there, guys, you will be able to easily, okay, understanding. So if you all if you all try to understand here, if you apply a little bit of common sense there, then you will be able to easily remember that one. It is not always like mugging up the epithelium, guys, but you have to revise all that 3 tables that I showed you before going to the INSET exam, sir. Welcome to the concept number 18, sir. Next one is about the types of joint. Types of joint is also asked in the exam a lot of times. In INSET exam, there was a question based on syndesmosis, guys. In INSET exam, there was a question regarding syndesmosis. Okay, examples of that. Now, when it comes to types of joints, there will be actually 3 types of joints here. Remember, number 1 will be actually the fibrous joint. Fibrous joint means immobile joint only. Fibrous joint is nothing but the immobile joint. Okay. And the second one will be the cartilaginous joint here. Okay. And the third one will be actually the synovial joint here, sir. Fine. So the fibrous joint, the cartilaginous joint, and then you actually have got, yes, the synovial joint here, the movable one, guys. Now fibrous joint is the one from where mainly the questions are being asked nowadays. Number 1, fibrous joint. The fibrous joint is the one, number 1, which will include the sutures. Sutures, the immobile ones, okay, of course. Number 2, it will be actually including the joint between the gum and the socket there, that is gomphosis. And number 3, there will be one more joint, that is actually syndesmosis. And from there, the question was asked in the INSET exam 2020, guys. Is it okay? Fine here. The sutures, gomphosis, and then syndesmosis. Now, please look at this diagram here. I don't want to go into all the sutures, sagittal suture, lambdoid suture, the parietal suture, and all those things. But the important one, I hope you have learned this n number of times on the online platforms. YouTube sessions I have taught this, that is your H-shaped suture, and that H-shaped suture is actually the one which will be your pterion, the pterion. That H-shaped suture, that is nothing but the pterion. Pterion has been asked a lot of times in your AIMS exam as well as the INSET exam, guys. First of all, this H-shaped suture, that is your pterion, is formed by 4 bones there. Okay. Number 1, there will be the frontal bone here. Number 2, the parietal bone over here, and then there will be the temporal bone over here and the squamous part of the temporal bone, squamous temporal bone there. Okay. And then this actually the sphenoid bone, and that is the greater wing of the sphenoid, sir. Greater wing of the sphenoid, guys. Okay, that is the greater wing of the sphenoid there. Fine. So please keep that in mind there. That is the greater wing of the sphenoid is the one which is going to form the pterion. I'll even write down there. The pterion formation is by the greater wing of the sphenoid. Now, I'll tell you why I'm actually stressing a lot here. Recently, the question was, what is the bony structure present on the inner side or on the inner side of the pterion? The bony structure present on the inner side of the pterion will be actually the lesser wing of the sphenoid. I'll show you the picture here. As you can see, on the inner side, you'll be actually able to appreciate the lesser wing of the pterion. Lesser wing of the sphenoid will be present on the inner side of the pterion. That is why I'm telling you here carefully. Let me just repeat that again. Pterion is actually a H-shaped suture, and that H-shaped suture is formed by 4 bones there. One is frontal, one is parietal, one is the squamous temporal, and another one will be the greater wing of the sphenoid. And what they have asked in the exam, what is the bony landmark on the inner side? The bony landmark on the inner side will be lesser wing of the sphenoid will be present there, guys. And about the artery, I don't even have to tell you people, you're all expert there. What is the artery underlying that one, guys? The artery underlying that one will be your middle meningeal artery, and that to the anterior branch of that one. Middle meningeal artery, and which branch of that one? The anterior division of that one, sir. Anterior division of the middle meningeal artery. Done. Next one, I told you, I don't have to show you the picture. Sutures is done. I don't have to show you the picture of gomphosis. Gomphosis is just the joint between the tooth and the socket there. Third one, I told you syndesmosis. Syndesmosis examples very much interesting here. Number one diagram that you are able to see here is the tibia and the fibula here, and the inferior tibiofibular joint. Number one example here, inferior tibiofibular joint. What are the example of syndesmosis? Okay. And then number two, yes, the middle radio-ulnar joint. The middle radio-ulnar joint. Inferior tibiofibular joint here, number one, and then the middle radio-ulnar joint. Another example of syndesmosis. And not only that, one more is actually between the sacrum and the the hip bone is actually the ilium part there, the iliosacral. Okay, na? So that joint is also one of the example of your syndesmosis, guys. So these three examples you actually have to remember there. These three examples you have to actually remember there, guys, about syndesmosis. And yes, in the recent INSET exam, they have tested about the middle radio-ulnar joint. Perfect. And the third category actually I told you about is the synovial joint, guys. Before moving on to the synovial joint, I'll tell you one more thing here. The joint between the rib and the costal cartilage. The joint between the rib and the costal cartilage, that is the costochondral joint. Costochondral joint. The joint between the rib and the costal cartilage there, guys, that is nothing but the costochondral joint. And remember that the costochondral joint is an example of your primary cartilaginous joint. That is one of the example of your primary cartilaginous joint. Primary cartilaginous joint, sir. Then what about the joint between the costal cartilage and the sternum there, guys? The costal cartilage and the sternum, that joint is actually the synovial joint, and synovial, that too plain synovial. So the joint which I am actually marking with the blue color over there, that is actually between the cartilage and the sternum. So that is nothing but the chondrosternal joint, and chondrosternal joint is actually the synovial joint. Very good, MacDoc. I am actually looking at your comments there in the phone here. Yes. So the joint between the cartilage and the sternum, that is the chondrosternal joint, will be actually synovial, that too plain synovial joint. But you have to remember, except the first one here, and the first one is actually a kind of fibrocartilaginous joint, guys. Fine here. So take care about this one here, guys. And I don't have to tell you about the secondary cartilaginous joint. I hope you remember that that key word for secondary cartilaginous joint. The secondary cartilaginous joint are all examples of that will be the midline joints in the middle of the body, exactly in the middle of the body. Mandibulosternal joint, xiphisternal joint, all those midline joints will be actually the examples of your secondary cartilaginous joint. Next one, yes, ear ossicles. We all know very well the three ear ossicles, that is your malleus here and the incus here and the stapes here. Fine. Can anyone tell me the joint between the incus and stapes, incudostapedial joint, it is an example of which one? The joint that is also plain only, doc. Okay. Yes, the joint between the incus and the stapes, incudostapedial joint, it is an example of which joint? Which type of joint is present over here? Yes, you will be surprised to remember, listen here, that will be actually one of the example of your ball and socket joints. Incudostapedial joint is actually the ball and socket joint. Fine here, ball and socket joint. Yes, that's what I am telling you. The moment we say the ball and socket joint, only two things will come in our mind, that is your shoulder joint, another one will be the hip joint. But my dear friends, please remember there, you forget about the shoulder joint, you forget about the hip joint, remember about the joint between the incus and the stapes there. So incudostapedial joint will be the ball and socket joint, and another one will be the talocalcaneonavicular joint in the foot. Talocalcaneonavicular joint in the foot will also be one of the examples of your ball and socket. And yes, some of the students are telling about the saddle. Saddle is actually between the malleus and the incus. The malleus and the incus, there will be saddle joint. Next one. So mainly, yes, Mainly here, this one here, guys. The important joints I'm actually trying to recall here. I'm not wasting your time by telling you about the shoulder joint, elbow joint. We already know that it is ball and socket, hinge joint and all. So the main important one where the confusion can occur. Now, what is the joint between the atlas and axis here, guys? Atlas and axis, that is your, the first cervical vertebra and the second cervical vertebra, atlas and axis, atlantoaxial joint. What is that joint? That joint is the one where you actually have the odontoid process on which another bone is actually going to rotate there. So that is an example of which type of joint there? That is your pivot joint. So atlantoaxial joint is actually the pivot joint here. Then what about the atlanto-occipital joint here, guys? Atlanto-occipital joint here, that is actually the ellipsoid one. Okay. Yes, very good, Karthik. Very nice. Very nice, Karthik. Very good, Nirupam. Very good, Harsh. Very good there. Okay, that is a pivot then. And then atlanto-occipital joint, there will be the ellipsoid joints. So these are all the joints that I want you to keep in your mind, sir. So at least these diagrams, if they are there in your mind, instead of just mugging up like all the examples there, better learn with the help of this diagrams there. Okay, easy to remember. Now welcome to the concept number 19 here, that is development of diaphragm. Another very important topic, guys, development of diaphragm there. Diaphragm will be actually developing from 4 sources, as you all know. Diaphragm will be actually developing from 4 sources, sir. Okay. Number 1 will be the septum transversum. Septum transversum, which is the one which is actually going to form what? The central tenon of the diaphragm. Number 2 will be the pleuroperitoneal membrane. Pleuroperitoneal membrane. Okay. And then number 3 will be actually the somites. And in this, remember, it will be actually the cervical somites. That's the term which is actually confusing many students. Cervical somites, or you can use the word as myotomes also. Okay. Cervical somites or cervical myotomes. Why it is confusing many of the students? Yes, here actually diaphragm and cervical, students will be thinking there is no connection between them, but remember about the phrenic nerve. The logic to remember, phrenic nerve is actually originating from C3, C4 and C5. Okay. Then after that, my dear friends, remember one more thing, that is the dorsal mesoesophagus. Dorsal mesoesophagus. These are the 4 sources from where your entire diaphragm is developing. But I don't want my student to just simply mug up these 4 words here. Diagram is important. It was given as an image based question in the AIIMS exam. AIIMS examiner has given this one as an image based question actually. So let us just draw a diagram here like this, sir. For example, if this is the superior view, we are looking at the diaphragm from above. Superior view of the diaphragm. Somewhere here we'll be actually having the septum, that is your septum transversum. Okay, that is the septum transversum over here. So that is the one which is going to form your central tendon. Now what is going to pass in the middle here? So that is your esophagus. And what is going to happen here? This one will be the dorsal mesoesophagus. This is actually the dorsal mesoesophagus here. Okay. And then, yes, you will be actually having the somites here. They are the one which are going to form that muscular part, the body valvular part. And whatever is left in the middle, that is nothing but the pleuroperitoneal membrane. It is paired on either side. That is pleuroperitoneal membrane, guys. Okay, fine here. So why I'm asking you to actually draw the diagram in your AIIMS exam, it was actually given something like this. Let me take another color here. For example, septum transversum number 1, pleuroperitoneal membrane number 2, cervical somites or myotome number 3, and dorsal mesoesophagus number 4 here. Number 1, number 2, number 3, number 4. Diagram was given, and in that diagram the question was, which of the following structure is responsible for congenital diaphragmatic hernia? Congenital diaphragmatic hernia will occur due to what? Everyone knows that, that is pleuroperitoneal membrane, but you should be even able to identify in the diagram also. The congenital diaphragmatic hernia will be the one which will occur due to a defect in the pleuroperitoneal membrane, and you should be able to identify that one, guys. Is it okay? So if that pleuroperitoneal membrane is not at all formed, then it will lead to congenital diaphragmatic hernia, and the contents in the abdomen will actually herniate into the thorax, compressing the lung on one side, leading to hypoplasia and all those things. Next one, sir. The last and final concept, of course, the muscles of mastication. There are 4 muscles of mastication, you all know very well. This one will be the masseter, and this one here will be the temporalis, and then the lateral pterygoid and the medial pterygoid, guys. Easy to identify. Lateral pterygoid is the one which will be actually going and getting inserted onto the temporomandibular joint there. So that is your temporomandibular joint, and the lateral pterygoid muscle is the one which will be going and getting inserted into the, the capsule of that one. Is it okay? Fine here. So these are the 4 muscles of mastication, but the catch here is to identify in this diagram. This is the catch here, guys. In the AIMS exam, another hot favorite topic of AIMS exam, muscles of mastication, I think 2017, 18, 19, continuously they have been giving, like almost every exam, muscles of mastication in one or the other section, whether it is coronal section, transverse, blah 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 blah. Now in this diagram you can easily identify here, guys, this one is actually your mandible, and the one which is inserting on the lateral surface of ramus of the mandible, this is masseter. On the lateral surface of the ramus of the mandible, that is your masseter there. Fine. And this one, which is the muscle which is actually coming from your temporal fossa over here, this muscle here will be the temporalis muscle. So that is temporalis, and this one is your masseter here. And guys, what is the muscle? What is this bone in the middle here? That is your sphenoid bone. And sphenoid bone actually will be having that, sphenoid bone will be actually having the medial pterygoid plate and the lateral pterygoid plate below. But one thing that has to be like printed in your mind, the one thing that that has to be like printed in your mind is that medial pterygoid plate has nothing to do with the muscles of mastication. It is only the lateral pterygoid plate. And lateral pterygoid plate, lateral surface, lateral pterygoid muscle, and the medial surface, that will be the medial pterygoid muscle. So it's only one, that is your lateral pterygoid plate, not the medial one. So out of these muscles here, which one will be the medial pterygoid and the lateral pterygoid? Remember, this one here, this muscle over here will be actually the lateral pterygoid muscle. Okay, the lateral pterygoid muscle, guys. Why? Because you can easily identify that lateral pterygoid muscle there. Why? Because that is the one which is actually going back. I showed you in this diagram here. That is the muscle which will be actually going back. So the muscle fibers which are actually going in the posterior direction and going and getting inserted onto the capsule, posterior direction and getting inserted onto the capsule of temporomandibular joint, and then easily you will be able to identify, yes sir, that is your lateral pterygoid muscle there, guys. Is it okay? Why? Because medial pterygoid muscle is again going to insert where only? Onto the ramus of the mandible, but on the inner surface, on the medial surface. Okay, not on the lateral surface, on the medial surface. Understanding? So that is the best way to identify. So remember this concept also, learn everything about the muscles of mastication also, and please go to the exam, guys. So these are all the important and very high yield concepts which you should not leave and go to the exam. Okay, you have to revise all these concepts. So all these concepts that I told you, you must and you have to learn. And I'm expecting the questions to be asked from here in the INSET exam, guys. Okay, so hope your preparation is going good. All the best. Attend all the lectures of the QRP session, guys. All in our doc tutorials YouTube channel, we are having all the 19 faculties, national level faculties teaching you here the QRP session. Take the best advantage of that. Daily in the evening time or whatever time is given, whatever schedule is given, attend that, and almost everything will be revised, and that will give you like more confidence. Okay. So hope this was beneficial to you people, and whatever like 2 hours that you have spent with me, or 2.5 hours you have spent with me, hope all these concepts were useful to you guys. Okay, a little bit of reflection, and please don't leave these concepts, and without learning this concept, please don't go to the exam, guys. Okay, so all the best. Thank you all for listening to me, guys. Stay blessed, and all the best for your exam.